Good morning, everybody. All righty, Kelly, if you would please watch for our last members and invite them in as appropriate, I would consider that a huge favor. Thank you very much. And with that, good morning, everybody. My name is Laura Carroll. I am the president of the Medical Services Board, and I am calling this June 2026 meeting to order. Mr. Sykes, would you please start with roll call?
This is Chris Sykes, certainly. Laura Carroll.
Present, good morning.
J.K. Costello. Expected. Morgan Honey.
Here.
Amanda Jaslinski.
Here.
William Kennard.
Here.
Barry Martin.
Here.
Cassandra Littler.
Here.
James McLaughlin.
Here.
Christina Mulkey.
Here.
David Pump.
Here.
Madam President, we have a quorum.
Wonderful, and we will continue to watch for our friend Dr. Costello. All righty, let's kick off with announcements. I'm going to start with our regular announcements first, team. The date and location, do we know what the location truly is? One moment, point of order. Do we know what's going to happen next month? Should I still read off that address the same way?
This is Chris Sykes. Yes, we don't know what's going to happen next month, so we are going to proceed as if June is the anomaly.
I hope it is the anomaly, so that's perfect. Thank you. I will start again. Good morning, community. The date and location of the next Medical Services Board meeting is scheduled to be held Friday, July 10th, 2026, beginning at 9 a.m., virtually and in person at 303 East 17th Avenue, 11th floor conference room, Denver, Colorado, 80203. If you are listening via audio stream and lose the connection, please click again on the link to rejoin the meeting. Closed captioning is available on your Zoom toolbar and staff will chat out instructions. Please identify yourself when speaking comments. They are part of the public record. It is the responsibility of the Medical Services Board to adopt the rules that govern the department's programs through consideration of stakeholder input in alignment with the department's mission and in the best interest of all Coloradans. There is a testimony sign up for each rule, which was closing at the head of this meeting, if I am not mistaken. So testimony is now closed. We will be keeping testimony to 2 minutes per testimony today, and we will ask you to please keep your testimony related to the rule being discussed. All righty, community. There's been a lot that's gone on this last month, and that is why we are not all together. And I have prepared a statement that I'm going to read. And we're also going to hear from Gretchen Hammer this morning, who I also know has some things she'd like to share. Good morning, everyone. This month's meeting looks and feels a little different, so I wanted to take a quick minute to talk about it. This last 6 months or so, these Medical Services Board's meetings have been hard for everyone. HCPF, this board, stakeholders, members, everyone. I lose sleep. And I know my colleagues on this board lose sleep too. I'm also a Medicaid member, and my husband is on a waiver. So I feel the strain on multiple sides of my life. All that being said, it's time to take a temperature check and review our rules of engagement. I expect everyone to feel safe in my meetings, and that is not the case today. Members of my board are expressing concern about showing their faces during these meetings for fear of retaliation. Let me assure you, this team of professionals wants members to have access to the most benefits as possible, full stop. We cannot control the changes coming down from the federal level. And when we can eke out anything additional for our members, we question it on the spot and request rewrites, because that's our job. All of us take it very seriously, and we value your input through proper channels. We do not expect to be contacted at home, at work, by phone, or via our private social media accounts. And of course, and I'm sure you can hear it in my voice, I'm very sad that I have to say this, threats are never acceptable. Please only contact us through the official email channels provided by the state. Kelly is going to drop those into the comments now and throughout the meeting for me. And that is how we will continue to communicate with the board going forward. I appreciate your cooperation. This also holds true for the hardworking people that work for HCPF. These individuals, I promise you, are not cutting benefits for any sort of thrill. Many of these hardworking folks are single parents, former Medicaid recipients, and let's be honest, working for far less than they could be in the private sector. They are in this line of work to make everything better for every single person that they can. There's never, ever any reason for any of these dedicated public servants to be threatened, attacked, or otherwise assumed to be bad players with ill intent. This is not how we Colorado. We're better than this. So, Gretchen Hammer and I had to meet this week and weigh out our options. It was no longer responsible for us to gather our teams in environments where they didn't feel comfortable. We agreed, and we looked at either moving the meeting to a smaller location where we could have state patrol in the room, or going fully virtual. I chose the latter for my team, as did she. We would rather all of us gather on a Zoom screen than be surrounded by law enforcement, especially during these times when many of our most vulnerable actually feel less safe in that environment. I own this decision. I take full responsibility for it, and let's see how it goes together. We have an extremely full agenda today, team, that I am pretty concerned about getting through. So I'm going to end this right here. My hope is to return to a hybrid environment next month. Together, we are the only ones who can make this happen. Thank you, team. All righty, and with that, who do we have department updates from today, Chris?
This is Chris Sykes. We have Executive Director Hammer and Medicaid Director Adela Flores Brennan with us.
Oh gosh, we get you both. This is wonderful. Good morning, everybody.
Good morning. This is Gretchen Hammer. I am the new Executive Director of the Department of Healthcare Policy and Financing, and I am very pleased to be with you today. I want to start first by thanking Laura. Laura, thank you for your leadership. Thank you for your clear and heartfelt words. And thank you for working collaboratively with me and the rest of the team over the last month to ensure that this meeting is as productive and as safe as possible. I really appreciate the Medical Services Board and the role that you all play in helping us move our rules and regulations through so we can properly administer the Medicaid and CHIP programs, as well as other programs managed by the department. I had the opportunity to serve, as Adela does, as the liaison to the board when I served as Medicaid Director over 8 years ago. I'm pleased to be back with you here today, and I thank also the members of the public who have joined to both participate and to share your perspective with our board as we move forward. I will keep my comments short as well because I know Adela has some additional things to share from the department. But again, I want to thank you, President Carroll, for your kind and thoughtful words. I want to thank everyone for your participation in this critical point of democracy, right? This is the place where laws become rules and regulations become benefits that serve our members. So thank you for your participation today. I look forward to hearing the conversation. Adela, I'll turn it over to you.
Okay, thank you, Gretchen. Good morning, everyone. Adela Flores Brennan, Medicaid Director for the department. I'll start with my usual updates. And the first one will be about our non-emergency medical transportation broker. The model is going to be changing, and we are transitioning to a new vendor. So the new vendor is MediDrive. They were selected as the new broker to manage NEMT, and they will do all the provider credentialing, the network management, trip scheduling, billing and payment. The changes will be happening in two separate phases to support a statewide rollout. So we're going to be moving to having the broker service the entire state, which is not the case right now. Phase 1 is effective July 1st, and the broker will begin taking over in the 9-county metro area where our current broker, TransDev, is currently operating. So those counties include Adams, Arapahoe, Boulder, Broomfield, Denver, Douglas, Jefferson, Larimer, and Weld. Members in this region will start using MediDrive for NEMT services. Members outside of the Denver area can continue working with their local providers. And then later this fall, we'll start transitioning those other 55 counties. Ahead of the July 1st transition, we have already contracted with more than 120 transportation providers in the metro area. That's by comparison to 85 that are currently contracted with our existing broker. So that part is going well. And members can learn more by visiting our benefit page, and we'll provide some links in the chat. More about the NEMT service and what providers need to know can also be found on our policy page. Again, we'll be posting links in the chat. On July 1st, we expect also, in moving to other announcements, to launch our reentry services. So people who are leaving incarceration will begin to receive new benefits under our 1115 waiver, and that's in partnership with the Department of Corrections. And then federally, you are probably aware that CMS has released what is called an interim final rule. They released that on June 1st, and that is providing much anticipated guidance on the implementation of HR 1, which is the big piece of legislation that is bringing a lot of changes to Medicaid and other public benefits programs. I will say that there are some things that we are going to need to change in response to that regulation. There were some clarifications that we are seeing to be a little bit more complicated than what we initially understood. So we are really working to understand that new language and incorporate it into our IT systems and operations. So more to come on that, but I will say as well that we have launched our education and outreach campaign. We have the toolkit up and running on our website, and that has early messaging about what people can do to be prepared. And then also a reminder that we have a screening tool on our website that people can use to figure out if they may be required to comply with the work requirements that are upcoming. We hosted a webinar on June 2nd, and so that is also on our website if you wanted to go back and listen to the recording, and there will be lots more meetings and webinars coming up. So those are some of our big announcements and changes that are coming our way. I will just again repeat and reiterate my thanks to Laura for her opening statements and kind words. And I want to also extend my welcome to everyone to our June 12th meeting and say that we do value your public input, and we value and respect robust feedback and even criticism of our proposed policies. Those are welcome. What is not, again, are the personal attacks, insults, and threats, which is, again, why we are hosting the meeting fully online. So I will just ask and provide an advance thank you to all of you for helping to maintain a respectful and productive meeting. And we look forward to hearing from you. So thanks very much. And I'll turn it back over to you, Laura. Thanks.
Thank you. Be patient with us today. We're not in our usual IT environment either, so we're not pushing our usual buttons. So you might see some delays in between when we say back to you and then no back to you happens. I appreciate the grace today. Thank you very much. All righty. With that, team, I would entertain a motion for the approval of May minutes.
Madam Chair, this is James McLaughlin. I so move.
Good morning, Mr. McLaughlin. Thank you. May I have a second?
This is Amanda. I second.
Thank you, Amanda. All in favor, please say aye.
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 I saw your hand, Dr. Kennard. Thank you. All opposed? Abstentions? Terrific. That passes. Team, I'm going to take 2 seconds here to give you all something to think about for next month's meeting. I would like to think about moving our minutes to consent agenda. That is a pretty common and normal practice in other municipal environments. We do not have time to have a lot of talk about it today, but I think that is something we should do moving forward. It'll make our meetings shorter, more streamlined, and more aligned in what most municipal environments do. Just something to think about. I'm going to bring it up next month. We don't have time now. All righty. With that, we are at the final adoption by consent. Team, we have to have a little talk first. Rule number 2, someone has signed up to provide testimony. We do have this very thick, deep, and rich meeting with many people signed up for many different topics. And last month, you team voted to put this on consent. So I do not feel comfortable being the person making this decision. Plus, I love buck passing. So I know, right? Do we want to pull Rule 2 off consent, or do we want to leave it on consent? Because if we bring in testimony, then we go through that whole process. I was not here for that full experience. I only go from what I read and heard. So I really could use some feedback from my board of what we would like to do. Okie dokie. If we're not going to hear, then I'm going to make a managerial decision, team. It looks to me like JK has written he would like to keep it on consent. I think that would.
Madam Chair,
sorry.
Yes. This is James McLaughlin. I concur.
All righty then. My apologies to the person who signed up for document 2. We did make a decision in last month's meeting to move that document to consent agenda. So we are going to move forward with consent agenda. And if I can please have somebody who is willing to take that motion on, please.
I can do that. I just need to find this is Cassie Littler. Let me find the document. Hold on one second.
I appreciate you take your time. We're all on our Plan B day, so, we will once again and throughout request much grace.
Thank you. Okay. I move the final adoption of document 1 MSB 25-10-22-C, repeal to the medical assistance rule concerning adaptive therapeutic equine activities, section 8.7524, document 2 MSB 25-11-05-A, revision to the medical assistance Act rule concerning medication administration, section 8.7414, document 3 MSB 25-08-27-A, revision to the Medical Assistance Act rule concerning nursing facility reimbursement, sections 8.430 to 8.449, and document 4 MSB 25-08-11-A, revision to the Medical Assistance Act rule concerning state-funded supported living services, state SLS program, section 8.7560, incorporating the statement of basis and purpose and specific statutory authority contained in the records.
Thank you, ma'am. May I have a second?
This is Amanda Drushinsky. I second.
Thank you, Amanda. All in favor, please say aye.
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 All opposed? Abstentions? Very good. We are through the consent portion of the program. Very good, team. We are on to final adoption. And first we have document 5. And let's see, today we have Adam with us. Good morning, Adam.
Morning, everybody. Thanks for having us back. Really very excited about this rule. Excited to be talking to all of you guys. Over the past month, we've continued to work with our stakeholders and out and getting, including some provider agencies, some of the members that we heard from in the last presentation, as well as some case managers and the Peak Parent Center. After all of those conversations, we did not see a need to change anything within the rule, but what we did discover were more places where we really do need to focus in on some of the training. This includes some of the places like the milestones payments, and kind of talking more about the job development and how that is going to work. But all in all, we are really excited. I also want to point out that we were able to publish a fact sheet, and that is on our supported employment website, which is part of HCPF's website. And then also last month, a couple of questions came about what kind of data will we be able to share. And I just want to tell the board that we're expecting about 6 to 8 months for that data to be able to be large enough for us to be able to share. But some of those things that we are expecting to share is average hours worked, average income, how many people are currently employed. And then also we internally will be tracking some of these things so that we can, one, make sure that the rollout of this new model is rolling out effectively so we can reach out to those maybe areas or providers that are having a little bit more difficulty getting this up and going. So a lot of that has been really exciting work, and we're really excited to, and I'm hoping that it's just a couple of months and we'll have enough data to really be able to share. But we're expecting about 6 to 8 months for that data to be robust enough to truly share. And then the last thing, I just want to mention that I just got back from the National Association for People Supporting Employment First conference, and there was about 800 to 1,000 professionals there, and this model was a huge topic of conversation. People around the country are very excited about this and will be watching us. And this even included that one of our champions who works for Imagine. Her name is Sydney Elch. I think I said that correctly. She actually won a national award for the work that she did with us to help develop this, and also just the stellar work that she does in her day-to-day work with Imagine, the provider. So with that, I will stop talking, and I know we got a full day.
I appreciate you, Adam. Thank you very much. Do I have any questions from the board? I am hearing none. Mr. Sykes, do we have anyone signed up for public testimony today?
This is Chris Sykes. We do. We have Kristen Smith.
Good morning, Kristen. Good morning. You are off mute. Kelly, I'm not able to hear Kristen. Are you?
No, she is unmuted though.
I do see that.
Might need to do this is Chris Sykes, might need to do something to the phone, right? I mean.
Oh, hang on here.
Sometimes there's
yeah, she's showing off mute. Let's see, wait. Oh. Got all kinds of things moving on the bottom of the screen. I'm gonna lean on the people who are good at watching these screen things. I see, Kristen, I do see you. I do see you're off mute. Give us a couple of seconds. Again, we so appreciate your grace while we navigate in this new to us again environment here. So is she trying to comment in? While we're working on that, MSB team, I did see that you guys are sending me some comments in the chat. I do not see those. So if you need to speak to me, we're gonna have to probably get off camera or have you get on and talk to me because I can't keep track of the chat and all this other stuff today too. She doesn't not. All right. Gosh, this is frustrating for me. It's so important to me that everyone get heard. Is she the only person we have signed up for testimony, Mr. Sykes?
This is Chris Sykes. Yes, for this rule.
Okay.
Correct. Unfortunately, just the one individual.
Does our IT team have any other ideas?
Looking at you, Kelly O'Brien.
There's only the fact that we're allowing her to talk doesn't require her to override or press *6 or anything like that. So the only recommendation would be to switch to a different type of audio.
Hello, can I
Right.
be heard?
Oh, there you are.
Here we go. Wonderful. Okay.
Look
All right,
at us,
well,
day one, getting her done.
we had
Kristen?
quite a few issues there, but that said, I gave my testimony once thinking that you guys might have been able to hear me and I just might not have known. But that said, I did have quite a few questions on this topic after last month's MSB meeting, specifically in and around workplace assistance, but having the actual text is helpful, so thank you. So I will leave those questions aside. The one question I do still have is what happens if someone is employed in a seasonal work environment? How would that be handled if it is something that individual would be doing for, say, 6 months of the year, but perhaps from summer to summer or winter to winter?
Hi, Kristen. I do appreciate your question. This is Laura Carroll, president of the board. I'm not able to make specific answers to that. I can certainly refer that over to Adam if you wanted to try and clear that up for her.
Absolutely. So what we would see it is kind of a stopwatch, right? So somebody would have that seasonal work. They would use the supported employment phases and work through that, and then when that job ended, that stopwatch would end. So that the next year, if they went back to that same job, they would start in that same phase or in that same of job coaching and just continue with that timeline or that process, if that makes sense. Easier if I have slides, but I don't have one for that. Did that make sense, Kristen?
Did. Thank you. Appreciate it.
Absolutely.
Does that do it for you, Kristen?
It does.
Wonderful. Do I have any response from the board? Excellent. Do we have anyone else signed up for public testimony today, Mr. Sykes?
This is Chris Sykes. We do not have anybody else signed up for public testimony on document 5.
Wonderful. Then I would accept a motion on document 5.
This is Barry Martin. I can do that.
Thank you, Dr. Martin.
Move the final adoption of document 5, MSB 25-06-17-A, revision to the Medical Assistance Act rule concerning the developmental disability and supported living services, supported employment supports, and workplace assistance, sections 8.7549 and 8.7558, incorporating the statement of basis and purpose and specific statutory authority contained in the records.
Thank you, Dr. Martin. May I have a second, please?
This is Cassie Littler. I second.
Thank you, Dr. Littler. All in favor, please say aye.
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 All opposed? Abstentions? Wonderful. Document 5 passes, and now we are on to document 6 with Madeline Cotaro. Good morning.
Good morning, Madam President and members of the board. I am Maddie Quattaro. I'm in the Office of Community Living, and I am revisiting MSB 250917-A. So last month, you all had voted to approve my rule on initial adoption. As a quick refresher, this rule consists of several technical and clarifying changes to the regulations surrounding the Children with Complex Health Needs waiver, the Extraordinary Cleaning Service, and Community First Choice. In that meeting, Dr. Mulkey had requested that we change the name of the physician attestation of member capacity form to include other medical professionals instead of simply physicians, because in practice, the form is signed by other licensed medical practitioners, such as physician assistants or advanced practice nurses. We are open to considering this change. However, after doing some further digging, implementing it thoughtfully will require additional stakeholder engagement beyond what the timeline between initial and final adoption allows for. So given that timeline that we need everything that's in this current rule adopted, we are not able to make the requested modification to the form title at this time. We will continue engaging stakeholders and working through the necessary review process over the coming months to better understand the feasibility of changing the name of this form to include that population. I really appreciate your understanding on this and also appreciate your consideration on final adoption for MSB 250917-A.
Thank you very much. Do I have any questions from the board?
This is Cassie Littler. I just am wondering the additional stakeholdering that needs to happen. What does that include? What's the timeline? Just because, many advanced practice providers see complex patients, and we don't want to delay care to patients who are provided care by those providers.
Definitely. No, and that's a great question. And I do want to call out too that the form itself does say who can fill it out. So it is just the title of that form. But changing the title of the form it impacts all of our self-directed services. So in-home support services and consumer-directed attendant support services, or CDOS. And to change the name of that form, we would need to consult all of those members, the provider agencies that do that work, and then other stakeholder groups in and of itself. We have pretty robust stakeholder engagement practices with those groups, like monthly meetings, and we really like to be transparent and not change things kind of in this quick of a time frame. So I would say we've started exploring it and will further explore it over the next couple of months. And if we are able to make that name change, we would expect to be back probably end of summer, fall, maybe somewhere in that time frame.
Thank you for that. This is Cassie Littler again. So just to be clear, advanced practice providers can sign the form or fill the form out. It's just the title of the form that needs to be changed.
That is correct. And the form itself states that. It's just the title.
Thank you.
Do I have any other questions from the board? Hearing none. Mr. Sykes, do we have anyone signed up for public testimony on document 6?
This is Chris Sykes. We have, I apologize, I had it and now it's, Kira Hartman Judson.
Good morning, Kira. I am not seeing Kira.
Don't either.
Thank you, Kelly.
I do not see Kira online either.
All right, since we are not finding her on there, we're going to go ahead and move. Actually, let's give it a count of 5. Raise your hand or send me an emoji if you are out there. Okie dokie, we're going to go ahead and move on. Mr. Sykes, do we have anyone else signed up for public testimony on document 6?
This is Chris Sykes. We do not have anybody else signed up for testimony on document 6.
All righty then, I will accept a motion on document 6.
This is Amanda Jaschonski. I can take that.
Thank you, Amanda.
Move the final adoption of document 6, MSB 25-09-17-A, revision to the Medical Assistance Act rule concerning children's home and community-based services, community first choice, and extraordinary cleaning, sections 8.400, 8.7101, 8.7200, and 8.7500, incorporating the statement of basis and purpose and specific statutory authority contained in the records.
Thank you, Dr. May. Have a second.
Madam Chair, this is James McLaughlin. I'll second.
Thank you, Mr. McLaughlin. All in favor, please say aye.
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 All
Aye.
opposed? Thank you. All opposed? Abstentions? Wonderful. Document 6 passes. We are on to the initial approval portion of the program, ladies and gentlemen. And first up is document 7 with Amy Ryan. Good morning, Amy.
Morning. This is Megan Haynes. I'm actually covering this role this morning. So good morning, Madam. Oh, good morning, Madam President and board members. My name is Megan Haynes, and I am the Children's Health Policy Advisor in the Child Health Plan Plus program in the Health Policy Office for the department. I am here to present the CHP Plus Removing Coverage Limitations Rule, CHP 26-05-03-A. I am joined by Amy Ryan, Child Health Plan Plus Program Manager, who is available to assist with answering any questions you may have following the presentation. In 2024, the Centers for Medicare and Medicaid Services issued a final rule removing any dollar limit to benefits for separate children's health insurance programs. In Colorado, Child Health Plan Plus, or CHP Plus, has dollar limits on 2 benefits in rule at 10 CCR 2505-3, Section 210. Durable medical equipment, or DME, and vision benefits for eyeglasses have dollar limits that are being removed from policy and contracts effective July 2026. The DME benefit in CHP Plus has previously had a $2,000 per year limit with many exceptions, and the vision benefit allowed for $50 coverage of eyeglasses. This proposed rule change removes dollar limits on CHP Plus benefits, aligning the program with new CHIP federal regulation. CHP Plus members are most affected by this proposed rule change. These individuals will gain access to comprehensive durable medical equipment and vision benefits for eyeglasses without financial caps. This proposed rule change impacts Section 210J of 10 CCR 2505-3, removing the $2,000 per year limit on durable medical equipment, and Section 210Q3, removing the $50 benefit for eyeglasses. CHP Plus members whose medical needs would have exceeded the previous coverage limitations will have better access to health care, reduced financial stress, and better health outcomes. Eliminating coverage limitations will lead to a predictable increase in claims volume and costs for service previously capped. While managed care organizations, or MCOs, may bear some costs in communicating these changes to CHP Plus members, the cost of implementing the proposed rule is negligible. We have engaged stakeholders over the past 1.5 years through a variety of methods, including all MCO monthly meetings held in January 2025 and March 2026, a DME and vision stakeholder meeting held in February 2025, emails inviting feedback on DME and vision benefit changes to previously engaged stakeholders that were sent out in March and April of 2026, and a targeted email blast to vision providers inviting feedback on the vision benefit changes in March and April as well. Much of the feedback received from stakeholders was centered on how the vision benefit changes would be operationalized by Child Health Plan Plus managed care organizations. We have partnered with the MCOs to develop a CHP Plus vision benefit policy statement and CHP Plus vision benefit guidance, essentially a billing manual for vision services. Thank you for your consideration, and I am happy to answer any questions that you may have.
Thank you, Megan. That's okay. I had to read, again, had to read across our microphone. Thank you, Megan. Do I have any questions from the board?
Dr. Kennard here.
Go ahead, Dr. Kennard, and then Dr. Martin, I see you second.
Thank you very much for that presentation. I'm unusual one in these last 6 months to see something, as I understand it, increasing benefits and spending. I'm struggling to understand how there's no cost implications of taking off caps in these things, number one. And number two, my standard question, removing a $2,000 annual cap on DME and putting it in the hands of the MCOs, do we have guardrails in place to suddenly have everyone spending $25,000 on DME? What is to stop that from happening? Thank you.
Thank you for your questions. Certainly appreciate you bringing those forward. So our prior managed care rates analysis shows a minimal impact to the budget for these required changes. And so that is why we indicated that we see this change being negligible. Certainly understand concern about increased utilization when caps are lifted. And so there are other evidence-based limitations that are not dollar-based, and those inform the process. And Amy, please go ahead and speak more into that if you would like to do so.
Thanks, Megan. Good morning. My name is Amy Ryan. I'm the program manager for CHIP here at HCPF. Thank you for your question. The DME benefit actually had several exemptions to the limit over the years as multiple legislations put inpatient, outpatient materials for certain conditions, cochlear implants. So because we had so many exemptions to that limit, once removed, we perceived that there wouldn't be additional utilization because we've already kind of had those exemptions. And what's notable to point out here is that the federal government, the new rule in our regulations is requiring removal of dollar limits. So we can still have visit limitations. We can still have other medical necessity or evidence-based limitations. So these are just the few benefits we had in our rule that still had a dollar limit attached to it. I hope that helps.
Dr. Kennard here. Thank you. That does help. I think I would still hope to hear a year after the implementation of this rule, what had happened to the DME budget.
That sounds like a plan.
Thank you.
No problem.
All righty. I'm getting feedback again, Chris. I'm not sure what's going on here. Oh, there we go. You hear it coming back and back and back.
Everything your speakers.
It just stopped. Okay. All righty then. Dr. Martin, I did see your hand go up and down and up and down and up and down, and I promised you next, so I wanted to hit you before I went to Dr. Littler.
Well, most of my questions, this is Barry Martin, most of my questions were answered. I do think I often wonder when restrictions are imposed, how effective they're going to be. And this is an example of when we put restrictions in place, they were being overridden constantly, so it didn't accomplish anything. And so now the restrictions are being removed. So I congratulate the department on realizing that and bringing in this good news rule to us.
Thank you, Dr. Martin. Dr. Littler.
Hi, thank you, Cassie Littler. I wanted to clarify when you're talking about the MCOs for CHP Plus, that's primarily children and pregnant people. And so that would be Denver Health Medicaid MCO and the Rocky Mountain Health Plan Prime MCO for CHP Plus. Is that right? So these dollar limits are now taken off. But then the MCOs who get that kind of carve out dollars would have to also incorporate this rule in the delegated money that they receive. Is that right?
Close. So in Medicaid and Health First Colorado, you have Denver Health Medicaid and Rocky Prime. They are MCOs for Medicaid. They're also MCOs for CHIP. So we do have Denver Health, but they don't call themselves Medicaid. We do have Rocky, and they don't call themselves Prime for CHIP. And then we also have Kaiser and Colorado Access serving as MCOs for CHIP. So the rest of what you said is correct. That's being factored into their capitated rates that they negotiate every fiscal year. But we're a little bit different from the two MCOs that serve Medicaid, but not super different because it's Denver Health and Rocky with the same people, just a different line of business in addition to two more MCOs, Kaiser and Colorado Access.
Hi, team. Real quick, I wanted to interject and remind everyone that not everyone knows our acronyms, and we have been using MCO like it is common vernacular. So just as a reminder, that would be a managed care organization. Is that correct, HCPF team?
That is correct. In CHIP, we're a little bit different from Medicaid. We are full risk managed care. So we don't have fee-for-service physical health and behavioral health contracted in the Accountable Care Collaborative. Our whole program is with the managed care orgs as a full risk contract.
I appreciate that clarification for the folks at home. Thank you, Amy.
Thank you for your question. Thanks.
Absolutely. Dr. Littler, please continue.
No, that answered my question. I just wanted to make sure I had a better understanding because I know it's similar but different and can be confusing. Also, I think that to your point that you can still have other restrictions on DME, that's slightly different than a child who's on Medicaid who has the overlapping of EPSDT and medical necessity there, whereas that does not apply for CHP Plus. Early periodic screening, diagnosis, and treatment is what EPSDT is. Did I say that right? No.
Yes. And you are correct.
Okay.
ESP, oh my gosh, I say it all the time. EPSDT is mandated for Medicaid, but we don't cover it that way in CHIP. So it is viewed as like a utilization management according to medical necessity. We do use medical necessity, but we aren't held to the same standards as EPSDT. And that is, yes, thank you, Rachel.
Thank you, Rachel. Dr. Littler, are you all set?
I am, thank you.
Wonderful. Do we have any other questions from the board? Hearing none. Mr. Sykes, do we have anyone signed up for public testimony on document 7?
This is Chris Sykes. We do not have anybody signed up for public testimony on document 7.
Very good. Then I will accept a motion for document 7.
I'm happy to do that.
Thank you, Doctor.
This is Cassie Littler. I move the initial approval of document 7, CHP 26-05-03-A, revision to the medical assistance rule concerning CHP Plus, removing coverage limitations per final rule, sections 210J, incorporating the statement of basis and purpose and specific statutory authority contained in the records.
This is David. I second.
Oh, you're the best, David. All in favor?
Aye.
Aye. All opposed? Abstentions? Mr. Sykes, I just wanted you to note that Dr. Kennard did give us an aye with his hand.
Oh, thank you very much.
Very welcome. It is a teamwork, dreamwork situation. All righty, and with that, document 7 does pass initial approval. We are on to document 8 with Megan. Good morning again. Different Megan.
Yes. Good morning.
I'm sorry.
It's okay. It's Megan Crabtree. Can you hear me?
I do hear you.
Okay. Apparently we can't see me, but I promise
Well, we can see you. So that's the good
great.
news. I would like to point out, Mr. Sykes, that her name seems to be Morgan Honey.
I totally saw that. It's okay. Don't
He's a
derail.
really good guy, Megan. Don't worry, it's all good.
Appreciate it.
Go on ahead. We know it's you.
All right, thank you. This is Megan Crabtree. I'm going to be reading a statement regarding two rules today, CHP 2602-09-B and MSB 2602-09-A. And these are the amended definitions of qualified non-citizens for HR 1. Good morning, Madam President and board members. Thank you for your time today. My name is Megan Crabtree, and I am the Medicaid Eligibility Policy Specialist for this rule revision. I am here to present MSB 260209-A and CHP 2602-09-B concerning amendments to the definition of a qualified non-citizen and updates to citizenship and immigration eligibility requirements for medical assistance and child health plan plus CHP plus programs. These changes are intended to ensure that benefits are provided appropriately to eligible members and providers. The proposed rule changes amend sections 8.100.3.g medical assistance eligibility requirements, 8.100.4.g.6 legal immigration prenatal program clarifications, and 110.1.b CHP plus eligibility requirements. These rule updates implement federal requirements under One Big Beautiful Bill Act, or referred here as HR 1, provision 71109, effective October 1st, 2026, requiring states to ensure that full Medicaid and CHP plus benefits are provided only to individuals who are eligible for federal financial participation, referred to as FFP, based on their immigration status. The department is updating eligibility policies to align with the federal definition of qualified non-citizen. Full coverage will continue for individuals who remain eligible for FFP, including certain lawful permanent residents who are LPRs or green card holders who have satisfied the 5-year rule, Compact of Free Association migrants or COFA migrants, Cuban Haitian entrants, and certain pregnant individuals and children covered under the CHIPRA 214 option. The rule aligns Colorado policy with federal financial participation, FFP again, requirements and immigration eligibility standards. Failure to align this rule with federal law would result in a loss of FFP for the state and place the burden on the state to cover these individuals. The rule also updates citizenship and immigration verification processes and supports necessary changes to the Colorado Benefits Management System, CBMS. These changes include updates to eligibility determinations, verification procedures, and system interfaces used to validate lawful present and immigration status. In the following summary, the following is a summary of the rule updates. Section 8.100.3.g updates citizenship and immigration eligibility requirements for medical assistance programs to align with federal requirements for qualified non-citizen status and federal financial participation. Additionally, updates to reasonable opportunity period were added to align more closely with federal policy. Section 8.100.4.g.6 clarifies exceptions to legal immigration prenatal program locked-in requirements, providing additional guidance on circumstances when a member may no longer qualify for the program and when exceptions may be requested. Section 110.1.b updates citizenship and immigration eligibility requirements for Child Health Plan Plus, CHP Plus, to align with federal requirements for qualified non-citizen status and federal financial participation. The department will implement the necessary operational and system changes to support these updates. This includes modifications to eligibility verification processes, improvements to CBMS functionality. Lastly, the department would like to thank stakeholders CCDC and CCLP and partner agencies for their feedback throughout the development of these rules. I'd be happy to answer any questions. Thank you.
Thank you, Megan. I appreciate you. Do I have any questions from the board?
Dr. Kennard here.
Go ahead, sir.
A quick question and a comment. The question is, could you explain the 5-year rule? That's my question. And just comment. Of course, there's no surprise that there are no people who dare to provide public comment on this. And as I understand it, this means, for example, that an asylee who is here because he assisted American military forces in Afghanistan and was sprung out because those same military people helped him and felt very strongly about it, and now has a brain tumor, that he will receive a letter saying he no longer has any medical coverage. So we're going to hear a lot of human cost stories today, and I wanted to just point out those stories are everywhere. But my question is, what's the 5-year rule? Thanks.
Yes. This is Megan Crabtree. Thank you, Dr. Kennard. Yeah, the 5-year bar rule is a rule that was established in 1996 with the PWORA, and it's escaping me what that acronym actually is. It's like Public Works. It's where they established those rules on which immigration statuses are required to meet a 5-year rule from entry into the country, and those immigration statuses who are not required or exempt. Yes, thank you, Rachel. They're exempt from that 5-year rule. With these changes, and what that means, Dr. Kennard, is that these folks, there are some folks like the lawful permanent residents, LPR, would have to meet a 5-year rule, meaning they have to be in country for 5 years in order to be eligible, as long as they meet the other criteria for Medicaid. Other statuses, such as Cuban Haitians and the COFA migrants, they, per the PWORA, are exempt from the 5-year rule. They do not have to meet a 5-year rule to be eligible for Medicaid. I'm not sure if that answered your question or not.
Thank you, Dr. Kennard here. So just for my own sake, and maybe everyone else's, is LPR equivalent to a green card holder?
Yes, this is Megan Crabtree. They are typically known as green card holders, yes.
Dr. Kennard, thank you.
Thank you, Dr. Kennard. Do I have any other questions from the board?
Hi, this is Cassie Littler. I just was reviewing some of the written testimony, and I wondered if you could comment on what I had read about the CMS rule from April, being able to add in 3 additional, those granted asylum under Section 208 of the INA, refugee under Section 207, and a victim of severe form of trafficking in persons. If you could comment on if those are incorporated somewhere in there that I just don't quite track, or if those are unable to be incorporated into this rule as exempt from the 5-year bar after obtaining LPR status.
Those 3 groups are still exempt from the 5-year bar from the, and this is Megan Crabtree, per the PWORA.
Okay, so we don't have to call those out specifically as was suggested by testimony.
Not specifically, as the PWORA, the federal rule, does indicate that these members still meet that criteria.
Would that do it for you, Dr. Littler?
I think so. As long as they're in there somewhere.
The good news is if it becomes unclear again, I am happy to call on you twice.
Thank you.
Mr. McLaughlin, you're the next person in line that I see.
Thank you, Madam President. My question relates to the impact on providers as well. Do we have any clue what the actual fiscal impact of this will be on providers who are, I mean, they're still statutorily required to provide services in emergency situations?
Thanks, Mr. McLaughlin. This is Megan Crabtree. I am going to reach out to either Mitchell Scott or Director Adela to help me along with this question.
I'll jump in. This is Adela Flores Brennan, Medicaid Director. I'm not sure that we have a fiscal impact in terms of the impact on providers, but I think you are right that this is going to result in more uninsured individuals and therefore more uncompensated care or more access to emergency medical services. I guess on the good news side of that is that Medicaid will pay for emergency Medicaid. So to the extent that these individuals are still, income qualified for Medicaid or otherwise qualified for Medicaid, but for their immigration status, they would have access to emergency Medicaid. But yes, this is one of those provisions that is going to pretty starkly cause people to become uninsured.
Did that answer your question?
It did, Madam President. Thank you. And thank you, Adela. Yeah, I know this is one of those things that we just, it has to pass because it's mandated by the federal government. But I appreciate you pointing out that people who qualify for emergency Medicaid can still get that. So thank you.
Dr. Littler, you took me up on my offer.
This is Cassie Littler. This might be a question for Adela potentially. How does this impact CHP Plus members?
I can answer that. This is Megan Crabtree, Dr. Littler. It isn't really going to affect CHP members as CHP members fall under the CHIPRA 214 option. And there's not really a qualifying immigration status that is required. However, I did make updates to that rule to make the language a little clearer and update some of the terms that were used in that rule. But the folks that are eligible for CHP Plus are pregnant and children under 19, and both of those are exceptions to the immigration, the new definitions for the qualified immigration status.
Okay, thank you for that. So to James's point, those populations may have the opportunity to stay on, whereas if they were in the Medicaid population, they would not be allowed to stay on. So that would impact providers, well, obviously impact people, but then also impact how we care for those patient populations slightly differently. Okay, that makes sense. Thanks.
Thank you, Dr. Littler. Do we have any other questions from the board? Hearing none. Mr. Sykes, do we have anyone set up for public testimony on documents 8 or 9?
This is Chris Sykes. We have Carrie Jones signed up for testimony on document 9.
Wonderful. Are you out there? Oh, I see you. She is Carrie, good morning.
Good morning. Can you hear me?
Yes, that felt like victory. Thank you so much. You have 2 minutes. Tell us what we need to know.
Excellent. Thank you. Hello, members of the Medical Services Board. Thank you for the opportunity to comment. My name is Carrie Jones, and I'm here on behalf of Colorado Access, the state's largest and most experienced public sector health plan, serving roughly 500,000 Medicaid and CHIP members. I'm here to offer 3 comments, although some of them have been addressed already. Thank you, Dr. Littler. My first comment was addressed. It was regarding the continued 5-year bar exemptions under PROWARA for specified immigrant groups who go on to obtain their green card after October 1, 2026. So thank you for clarifying that comment. Second, we also recommend that the rule require the state to automatically transition members found ineligible for Medicaid due to their immigration status in October to emergency Medicaid and the reproductive health care services limited benefit programs. We are deeply disappointed and saddened that these individuals will no longer be eligible for full benefit Medicaid, but we strongly believe that the state should take action to ensure that they retain the highest level of Medicaid coverage for which they remain available or eligible after October 1. And finally, we understand that CHIP members will not be impacted by these changes. Thank you, Megan, for confirming that understanding. And we just encourage the state to clarify in the regulatory analysis and in future noticing explicitly that CHIP members will not experience any changes in eligibility due to immigration status, since this has been a repeated point of confusion in the community. Thank you for the opportunity to provide those comments. I sincerely appreciate your time and consideration.
Thank you, Carrie. We appreciate you. Do I have a response from the department?
Hi, this is Megan Crabtree. Yes, thank you, Carrie, so much for your feedback. And we will take that suggestion regarding EMS back for further consideration. Thank you.
Any response from the board?
This is Cassie Littler. I just had a question. So I guess what I'm understanding from that is that patients who have Medicaid and then who will no longer qualify for like regular full Medicaid don't necessarily just flip to emergency. Is that sort of what I'm hearing from that?
This is Megan Crabtree. Yes, Dr. Littler, that is correct. EMS is normally a selected enrollment by the member. They would have to request it. Is the normal process on how they would be enrolled. So that being said, if a member who would be losing coverage requested EMS prior to 10/1, they would stay enrolled in EMS after 10/1.
Thank you. I appreciate that. Did that get you, Doctor?
It did, and I appreciate you taking that back for consideration and thinking about how there could be like an ex parte situation or something where patients could flip more easily.
All righty, James, I see your hand.
Thank you, Madam Chair. Megan, just a really quick question. For those folks that are automatically unenrolled, to apply for emergency Medicaid, can providers use the Peak Pro system to do that on behalf of the client?
Thank you so much. It's Megan Crabtree, Mr. McLaughlin. I don't know that answer. I don't know if Mitchell Scott knows the answer to that question. I'm less familiar with the Peak Pro software. But if he's unable to answer that question, I can take that back and answer that for you in the next meeting.
Hi there, this is Mitchell Scott, Eligibility Policy Supervisor at the department. The provider on their end through Peak Pro, I don't believe that is functionality that's available. The member themselves, however, through the consumer-facing Peak website, they could certainly go in and request that, or they could also designate an authorized rep to help make that designation for them in Peak Pro. We can also do that over the phone or via mail. All the other modalities we have available for processing changes in circumstances, members could also utilize those avenues as well to request EMS.
Thank you, Mitchell Scott. Did that answer your question?
It did, thank you. Yeah, it did, thank you.
You bet. Any other questions from the board as a result of that testimony? Hearing none. Mr. Sykes, do we have anyone else signed up for documents 8 or 9?
This is Chris Sykes. I'm gonna verify. This is Chris Sykes. We do not have anybody else signed up to provide testimony on document 8 or document 9.
Wonderful. So we're going to do these one at a time, team. So first I will accept a motion on document 8.
Madam Chair, I can take that if you give me just a second to bring it up.
It is my pleasure, James. Thank you for taking the opportunity.
All right, I am ready when you are.
Hit me.
I move the initial approval of document 08 CHP 26-02-09-B, revision to the medical assistance rule concerning HR1 amended definition to qualified non-citizen section 110.1.B, incorporating the statement of basis and purposes and specific statutory authority contained in the records.
Thank you. May I have a second?
Barry Martin, I'll second.
Thank you, Dr. Martin. All in favor, please say aye.
Aye.
All opposed? Abstentions? Wonderful. Document 8 passes. Let's do the same thing with document 9, team. Who's going to motion for me?
Madam Chair, I've got 9 up if you'd like.
Oh, please, sir.
I move the initial approval of document 09 MSB 26-02-09-A, revision to the medical assistance rule concerning HR1, amended definition to qualified non-citizen section 8.100.3.G and 8.100.1.G, incorporating the statement and basis and purposes and specific statutory authority contained in the records. And this is James McLaughlin.
This is David. I second.
Thank you, Mr. Pump. All in favor, please say aye.
Aye.
All opposed? Abstentions? Wonderful. Document 9 passes. Y'all, we just got through 9 rules in an hour and 12 minutes. I think we deserve a gold star. But instead, I'm giving you a 10-minute break because now we get into the good stuff. So we are in recess for 10, team. Hello, everybody.
We could please, this is Chris Sykes, if we could please come back to order. Our 10 minutes is up.
Wakey, wakey. I'm going to give about 10 seconds to up there. Look at all those faces coming up and looking at me.
That's right.
That's right. All right, let's see here. Let's see. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Team, let's hit it.
It's because they're not on camera.
Right. I'm going to assume that you're all here. So, guys, we are off to the emergency adoption portion of the program. We are going to start with document A and our friend Stephanie Sawade. Did I say your last name right after I called you a friend?
Stephanie Sawade.
I was close. I'm sorry. Thank you.
You were close. It's a common mistake. No hard feelings.
All right.
Thank you for the
floor
attempt.
is yours.
Beautiful. Good morning, Madam President and board members. Thank you for the opportunity to address you all today. My name is Stephanie Sawade. I am the Eligibility Policy Specialist here to present MSB 26-05-28-A regarding an emergency update to medical assistance rule. This update will bring the department into alignment with House Bill 26-1411, which was passed on April 28th and signed into law on June 4th, 2026. The General Assembly reviewed the budget and determined the best course of action for cost savings by introducing several updates to the Coverall Colorado medical assistance programs. Many of these updates are effective January 1st, 2027. However, the enrollment cap update for children must be implemented by July 1st, 2026 to be effective for the 2026-2027 fiscal year. The proposed changes amend Section 8.100.3.G.1, regarding general and citizenship eligibility requirements to incorporate the approved House bill language for implementing the enrollment cap. The enrollment cap applies to children under 19 up to their 19th birthday month who meet all medical assistance eligibility criteria except for immigration status. This group is referred to as the Coverall Colorado Children's Coverage Category. The Budget Department will monitor enrollment in the Coverall Colorado children's programs. If enrollment exceeds 25,000 members or the quarterly budget is exceeded by more than 5%, an enrollment cap will be implemented. The enrollment freeze will be effective on the first day of the month, 60 days after the department determines one of the conditions has been met. The freeze will remain in place until the Budget Department determines the cap conditions are no longer met. Notification of reopening enrollment will be made publicly available through the regular communication channels. This cap applies to all children's Coverall Colorado programs. As long as enrollment remains below the cap and within budget, children in this population will not be affected. If the enrollment cap is initiated, children will not be assessed for the Coverall Colorado children's programs, but will still be evaluated for eligibility under all other medical assistance categories. The department will update the Colorado Benefits Management System, CBMS, to support this change. The department did not receive feedback or questions on the rule update for medical assistance, therefore no additional policy changes were required. Thank you to the Attorney General's office for their suggestions regarding this change, and thank you for your time today. I welcome any questions you may have.
Thank you, Stephanie. Do I have any questions from the board?
This is Cassie Littler. I just wondered if the department had a response of how feasible it is to jump on and off of Coverall with a cap like this on a quarterly basis with eligibility differences for children under a year and kids over a year. Just seems a bit confusing as a if you were a parent and as a provider of services to figure out if your patient could have Medicaid or not at any given time when you see them.
This is Stephanie Sawadi. Fair questions. We are still working on the feasibility of this switch and how that will exactly look for us. We are relying on communication internally with budget to really assist us with that. Right now, we were very focused on getting in alignment with the House bill. But we are working on getting more data and trying to figure out how that will look for us. I do welcome if Mitchell has any additional feedback to that as well.
Hi, this is Mitchell Scott, Eligibility Policy Supervisor. I just want to stress when this enrollment cap is hit, we wouldn't be necessarily disenrolling anyone from the Coverall Coloradans program. There is natural attrition to the program for children as they age out after they turn 19. But it would not be terminating anyone from the program specifically due to hitting that enrollment cap if that hits. And we are still, this was passed, as Stephanie said, signed into law only days ago. So we are still really working through oh my gosh, I can't say that word, operationalizing what it looks like when we hit that cap and when we turn that cap or turn that cap off. So we're really combing through all those details. But in terms of people going back and forth, that really shouldn't be something that we see when we do, if we do hit this cap. Hopefully that helps a little bit.
I don't know. I think from my perspective, this is Cassie Littler. Patients fall off of Medicaid all the time. And so it's hard to know what type of Medicaid they have. And so from a provider perspective, like I can't tell if they had regular Medicaid or if they had Coverall. And so if a patient falls off and they want to get back on, I'm not going to be able to tell them, yes, you can get back on because I don't know what type of Medicaid they have. So just communication about how this looks on the ground it will be really like an imperative, I think.
This is Mitchell Scott. Yeah, that makes a lot of sense what you're saying, and I understand a little bit more of the concern now. I think that's definitely something we can take back to the Coverall Colorado leadership group. And I do see Adela has her hand raised, so she might have some thoughts around that. I'll let you add anything additional, Adela.
Adela, you're on mute, my friend.
Yeah, I thank you. This is Adela Flores Brennan. I got some weird editing bar, so I was about to draw on my screen rather than unmute myself. So anyway, this is something that is like the visibility of the population of Coverall Coloradans was something that we did so successfully under the original legislation that we can't like providers and others cannot tell who is in this program versus regular Medicaid. And that was by design. That was how we understood the mandate of the legislation. As a result, changes to the program are that much harder, both internally to unwind and externally as we need to put different types of caps and other limitations on the benefit, it's going to be harder. So that is something that we are recognizing and very much are talking about internally in terms of how do we make this visible, because there are other things coming like a cap on the dental benefit and that type of thing. And so providers are going to need to know what type of benefit plan a person is enrolled under so that they can help manage to either benefit requirements or, in this case, enrollment concerns. So that is something that we are very much discussing, and we're conflicted, honestly, because the original intent of the legislation was not to be able to tell the difference between this population and other populations, and yet that makes it really difficult or infeasible to administer. So, and I do see a response in the chat. There was a question about how close are we to the proposed enrollment cap, and the cap is 25,000 in terms of numbers of individuals enrolled. And then currently we are at just over 20,000 children enrolled. I do understand, I think there is a budget cap also that we'll have to manage to as well. Those were both things that the Joint Budget Committee came up with late in session. So hopefully that helps just set some context and awareness about how we're working on all of these things.
I just have a follow-up question. So for instance, if we have a child who is under a year, they're continuously enrolled, and then they need to reapply, but they fall off. And so, because, you'll have to make sure that they're hitting their eligibility for the program in the first place. So they fall off, and then I guess our communication to families in this situation would be, you may be able to get back on Medicaid, but you may not be able to get back on. And so you really should just talk with enrollment services to see if you are still eligible, because there may or may not be a cap in place. I mean, I know we're way below the cap, not way below, but we're below the cap currently. But I guess communication about that is going to be really important. But I'm just thinking about how the eligibility, people fall off because they don't know that they need to reapply or update their information, that kind of stuff. So to your point, like it's really hard, but are there ways in which we can think about people who are going to fall off soon, and how to message them, I guess?
So this is Adela Flores Brennan. I think I am going to just take all of that, Dr. Littler, as advice for how we proceed with implementation rather than having an answer to the question in such early days of us trying to understand how to even implement something like this. So
Very fair.
we will
Thank you.
note that for our communications rollout plan.
That good for you, Dr. Littler? Awesome, thank you. Okay, so JK is having some audio issues today, so I've been getting some questions from him in the chat, and I just want to make sure we're covering him. It sounds like your first question was answered. Was that correct, JK? I can see your face if you just want to nod at me, or do you want me to reread that first question?
Oh, I don't have audio issues. I was just typing
Oh.
things into the chat. So you can answer them whenever it's convenient.
Okay, it's helpful on these if you would call out your questions, Dr.
Okay.
Costello, just because not necessarily do all the webinar people get to see all of those great and wonderful questions that you're asking. So I'm going to give the floor over to you to re-ask your questions.
Okay. I guess I'll read one into the transcript or so people can hear it. I asked how the current enrollment compared to the proposed cap of 25,000, and the answer as of 6/9 was 20,289, so about 19% below the cap. And then I asked along the same lines if there was a proposed budget cap yet and how it compares to current spending. And Adela is looking that up. So we can move on to Dr. Jastrzynski and come back to me.
Sounds good. Dr. Jastrzynski, good morning.
Good morning. I had more of a comment than a question, but I would just like to ask the department in the same spirit of James McLaughlin's comment with the last bills to try to keep track of the fiscal impact that this has on providers. Many practices already, especially ones that are safety net practices, run on really thin margins. We're already taking 2% Medicaid cuts across the board, and now might have more individuals who are uninsured who are seeking services in our practices. So I think it's really important that we monitor first and foremost the impact of this on the children who live in Colorado and their health, but also on the practices that try to care for them. That's all.
This is Stephanie Sawadi. Thank you, Amanda, for that feedback. We'll definitely take that back. I do want to add, similar to what Megan Crabtree stated, many of these members may have opted into emergency medical services. And if they have opted into those programs, if they're not able to qualify for any other medical assistance programs, they would be captured within that coverage category. But I do agree there's a risk of many people becoming uninsured with this program, so we definitely will take that feedback back. Thank you for sharing it.
Dr. Jastrzynski, does that do that for you?
Yes, ma'am. Thank you.
Wonderful. Do I have any other questions from the board? Hearing none. Mr. Sykes, do we have anyone signed up for public testimony on document A?
This is Chris Sykes. Sorry. Oh, too far. I apologize. Just checking real quick. This is Chris Sykes. We do not have anybody signed up to provide testimony on document A.
All righty, then I will accept a motion on document A, team.
This is Barry Martin. I can take it.
Thank you, sir.
Move the emergency adoption of document AMSB 25-05-28-A, revision to the Medical Assistance Act rule concerning updates to the general and citizenship eligibility requirements, sections 8.100.3, G, .1, Roman numeral 8, incorporating the statement of basis and purpose and specific statutory authority contained in the records.
One moment for a point of order, team.
You can read it.
I'm going to go ahead and read the beginning of the emergency adoption.
Sorry.
No, that's okay, Dr. Martin. I'm going to go ahead and read it in. It is something that we as a rule don't always hit like we need to, and I was hit over the head with a stick about it this morning, so I'm going to go ahead and do it. Move that all emergency rules that are adopted include a finding that their immediate adoption is imperatively necessary, to comply with state or federal law or federal regulation, or for the preservation of public health, safety, or welfare, and that compliance with CRS 24-4-103 would be contrary to the public interest. As a point of order, Ms. Weaver, do we need to reread emergency adoption info for document A, or can we just vote?
This is Jennifer. I think we can just vote.
Very good. All in favor, please say aye.
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 All opposed? Abstentions?
This is Amanda. I abstain.
Thank you, Amanda. That has been noted. One abstention. Very good. Document A does pass. All right. Good morning, Bonnie. You ready for document B, girl?
Good morning. Thank you. I think the screen says I'm also Morgan. I don't know if we can fix it on the back end, but for the
I'll have Chris change your name right now. But again, if you had to be confused for someone, Morgan's not too bad, although you're kind of prettier.
I apologize for that and agree.
I don't know that I agree, but I appreciate it. Good morning, Madam Chair, members of the board, and to many people from the community that are listening in. For the record, my name is Bonnie Silva, and I have the honor of serving as the Director of the Office of Community Living. I am here today to present two rules, the first which will place a cap on the number of hours an individual caregiver may provide to an individual member. Before I talk through the details of this rule, I think that it's important that I speak plainly about the impact. Behind every detail in this presentation is a family, a mother who has reorganized her entire life around caring for her child, who knows every medication, every trigger, every small sign that something is wrong, a spouse who made a promise years ago and kept it through hospital stays, sleepless nights, and thousands of acts that are quiet and filled with devotion that no one else will ever see. An adult daughter who moved back home because there was never any question that she would. These caregivers are not a line item in a budget. They are not a footnote in a policy. They are the reason that their loved ones are safe and stable. The care that they provide is skilled, it is constant, and it is given with a depth of love that no system could ever replicate or repay. I also want to be honest about how we got here because accountability matters. The department has built these policies with the right intention. We wanted to ensure that policy design and limits were flexible enough to meet the often very unique and complex needs of the people with disabilities that we serve. And I would venture to say that we have succeeded in many ways. But the current 112-hour limit on caregivers was never intended to be the norm. And quite frankly, we should have acted sooner. Families have built their lives around these policies as we have designed them, and I see and feel the very real fear and exhaustion expressed by many paid family caregivers about the personal impact of this policy change. I own that, and I believe the most responsible thing that we can do now is not to look away from this problem that the department certainly has created, but to fix it carefully, transparently, and with as much support for families as we can provide. So I want to be clear and say this from a very personal perspective. I understand that capping caregiving at 56 hours per week will be felt deeply in some households. For some families, this will mean real financial strain. For others, it will mean the painful work of letting someone new into their caregiving relationship that has been theirs alone. And I do not take any of that lightly. I want the family members here today to know that I have sat with your stories, I have read your letters, I have listened to your testimony, and so has members of my team. And they have stayed with us, and I hope that you can see that they have shaped this work and this regulation that I'm going to present today. With that, I kindly ask that we can move to the next slide, please. So I want to start out with what this rule does. This is a regulation that will limit caregivers to 56 hours of care per week per member across service delivery options. So this applies to both self-direction or agency-based care for personal care, homemaker services, health maintenance activities, which is the self-directed version of what you might see as certified nurse aide or CNA or registered nurse or RN level of care. It also applies to long-term home health nursing services and certified nurse aide services. So across all delivery models, this bucket of services and whatever combination is provided will be limited to 56 hours per week. It is a caregiver cap. I think it's important to note it's not a family caregiver cap. It applies to any caregiver that would be rendering this combination of services. We do understand, based off testimony and feedback, that it will likely disproportionately impact family caregivers. And working with the community, when we initially proposed this rule, it was set to be effective April 1st. Understanding the extraordinary impact that I referenced in some of my opening statements, we have worked with our elected officials to create a path forward that is a year long. So it would start July 1st. We would look at having a phased implementation to get us down to 56. So for members or for caregivers that are currently providing more than 84 hours per week to an individual caregiver, starting on July 1st of this year, those hours that they could provide would be dropped to 84. And then in January, that would then move to 70 hours per week. And then finally, with July 1st of next year, we would move to 56 hours. Additionally, we initially had very, very emergency-based narrow exceptions process in place for this policy. And again, listening to the community, understanding that we needed to have a better safety net for people for whom that really needed to have an exceptions to this individual caregiver 56-hour cap. And then looking at, in an emergency situations, how we were going to implement that. So we have made some pretty substantial changes in that regard. My intention is to go through that later in the presentation. So if we can go to the next slide, please. I think one of the things that as a department we have struggled to eloquently or adequately articulate, and I'm going to give it a go again, is that this rule really is aimed at addressing multiple challenges that are before us. We are looking at member safety and quality of care. We are certainly looking at the fiscal sustainability of our policies, and we are looking at where we have over-reliance on families and a disproportionate over-reliance on single caregivers in particular. Looking at national data, looking at local data, looking at how we have our policies set up, we know that it is the right thing to do for caregivers because no one can safely sustain 80, 90, 100 hours of caregiving every week without rest. We cannot say that we value caregivers and then build a system that depends upon their exhaustion. Sustainable care requires that caregivers also be cared for. It is the right thing for members because they deserve care from someone who is rested, healthy, and able to be fully present. And they deserve a program that will be standing for them next year, and 10 years, and 30 years. And it is the right thing for the program itself. These services are funded by a shared public commitment, and we have a legal and I would say moral obligation to steward these resources so that the more than 83,000 Coloradans with disabilities who depend upon this system can continue to count on it for many years to come. It is our belief that compassion and responsibility are not in conflict here, and that this rule asks us to hold both at once, and that is exactly what I am asking of the board today. If we can move to the next slide, please. In doing research around what was the right policy proposal to put on the table, we can see that 112 hours per week is more than 2 full-time jobs, and that fatigue related to that is not theoretical, that it's documented outcomes for caregivers with medically complex children can be very poor when we're not looking at how we balance caregiving responsibilities. We also know that there's a significant risk when we have a member become entirely dependent upon one person. If that caregiver is unable to provide that care for any reason, they become hospitalized, they become injured or otherwise unavailable, then we create this crisis situation where there is no backup plan. When we look nationally at what other states are doing around caregiver caps, and more specifically family caregiver caps, we are seeing that there, almost every state, there's been a lot of change in this over the last, I would say, several months as we watch a national dialogue around family caregiving, are providing more than 40 hours per week of caregiving, and that Colorado's 56-hour cap really exceeds that national norm, still allowing some nimbleness and flexibility, but bringing us more in alignment with what we are seeing in terms of what would be a typical policy here. So we believe that this is a step in the right direction. If we can go to the next slide, which I think is perhaps the most important component of this presentation, is where we can talk about allowable exceptions. We really worked hard to make sure that we built a safety net in the regulations around this policy. So in working with stakeholders, we now have exceptions for extraordinary clinical acuity. And you can imagine that this part is a bit difficult, right? Anybody who qualifies for long-term care is going to have complex needs. So working with the community to understand how we could really frame, who would qualify for this exception. So looking at complex medically fragile conditions with high risks of hospitalization or death, requiring really a strict limitation of caregivers that would be supported by clinical documentation is sort of option one for an exception. We also wanted to look at workforce access barriers. So understanding that there are some members that maybe live in rural or frontier locations, and because of that, just the pool, the options to attract caregivers is much smaller. And so we will have a process to allow for exceptions for that. The need for specialized skills that may be unavailable in a readily accessible way within our workforce is another component under this exceptions. A need for a caregiver that speaks a rare language. We know that communication, especially communication for people who may have atypical ways of communicating because of their disability, is really essential. So this is a component of what's covered under there. We also looked at transition or stabilization needs, knowing that the population served under the Office of Community Living, by virtue of their disability, may experience hospital discharges. They may have a crisis. And so like within 30 days of that hospital discharge, looking at providing an exception, looking at how we can leverage this exception process to improve stabilization periods following crisis, we also heard was an important component of what we included. And then recruitment or training after the loss of a caregiver. How do we make sure that we make that as seamless for that person as humanly possible? And then the last area where we were looking at exceptions is around end-of-life circumstances, where continuity with that primary caregiver really is essential to help that person die well and feel really supported. If we can go to the next slide, please. And actually, I'm just going to take accountability. I moved these slides around this morning. If we can just go to slide 8, and then I will come back to stakeholder engagement. Thank you. I appreciate that. And I apologize to everyone listening in for me moving fast here. So I want to go back to the exceptions process and provide a little bit more detail here. It is our intention that we have the exceptions process outlined in rule. What we heard from people was that it was really important that they could read in regulations what the exception process would be, that it would be objective and that it would be clear, which is a tall order, right? We want it to be objective and clear and also individualized. So working with the community, we have tried to achieve that. An example of that would be for the linking to the Colorado Rural Health Center, county designations map for rural and frontier definitions, talking about what clinical documentation for extraordinary clinical acuity or end-of-life care might look like. We also heard that, the importance of allowing for that member-specific individualized approach in their review. So we have asked that the provider agency be the lead in submitting exceptions. This was also a byproduct of feedback of really make sure that we are not placing any additional administrative burden that's unnecessary on case management agencies. And so the provider agency will be responsible for gathering that specific information and submitting it to the department. They also will, for members that have a case management agency, coordinate with them on the submission of this exceptions process, make sure that they're in the know and have the opportunity to review it. But really, they're the lead. The department is the reviewer, and working with the community, we understand that that is likely our best path forward for really reducing administrative burden around this. The department staff will look at the review of all the information submitted by the provider agency. If additional information is needed, we will absolutely request that. We want to make sure that we are doing our due diligence, that we are doing a thorough review of everyone who has raised their hand to say, I think I meet this criteria and here's why, and that we're doing that based off the information that we have. And if we don't feel like we have enough, we will ask for more. And I think another piece that people have raised is the department making clinical determinations? This is not a medical necessity review. This is really about, does that person meet the criteria outlined in rule for an exceptions? Is that documented and can that be approved? So if you can go back, just go to the next slide. I want to quickly speak about emergency situations. Thank you. This is another area in our policy, and I want to highlight for the board and for the community members that emergency situations do not require advance approval and they're not reviewed by the department. The expectation will be that the provider agency has documentation that supports why an additional hours were authorized to that individual caregiver in that emergency situation. We expect that they would be temporary. So initially we had up to 3 days. Based off feedback, we moved that up to 7. There are going to be unexpected or unscheduled things that happen. And what we want is not for this rule to create a barrier to people getting their needs met in those urgent and immediate risk situations. The key requirements under an emergency situation is that it's unanticipated. It's not foreseeable. This is something that really, truly, you can look at objectively and say, yes, I can see why that this classifies as an emergency. That it would be limited to no more than 7 calendar days. If the situation expands beyond that 7 calendar days, we would expect that that agency would be pursuing a more permanent exception. Assuming that that person would meet the criteria, and that it's necessary to address the need, and again, necessary to prevent a gap in critical services, and that it's documented and maintained in the member's record. If we can go back to slide 6, that would be very much appreciated. Thank you, and thank you to everyone jumping around the slide with me. These sustainability actions, started with the governor's budget, and in some cases, even before then, via the emergency order. And so I just want to name that, it is very atypical for the department to lead policy through the legislative budget process. And it does create some compression around how we engage around this work. But we know that hearing directly from people who are impacted, from disability advocacy organizations, from case management agencies, from provider communities and their trade organizations, is essential to make sure that we are really considering the impact of this rule from every perspective possible. So once we understood what would be approved through our legislative process, we have had our running shoes on, and we have held 2 dedicated meetings, one on April 30th, one on May 1st, aimed at taking feedback from people who really preferred to provide that verbally. We have issued 3 rounds of draft rules related to this 56-hour cap. Each have included dozens of changes made directly based off of that stakeholder feedback. And then we've certainly talked about and framed and engaged on sustainability webinars, talking about this work, helping to provide information to people so that they have it as we have it. If we go to the next slide, I'll tell you a little bit about what we heard. A little shockingly to us, what we heard is that the exceptions were too broad and that we needed to have more clarity. And so again, some of the changes that I talked about in terms of where we landed is we did really further redefine that criteria several times in particular to ensure that we were, clearly capturing the populations that we intended. We also heard, as I spoke about, is that making case managers gatekeepers for this would be administratively burdensome for members. And so have moved to make the provider the responsible party for submission. We also heard, issues around the timelines for the exceptions is too tight. You heard me say July 1st. And part of that, again, is because as soon as we got the information from the legislative process, here we are in the emergency rule process. I promise people we are moving as thoughtfully and as quickly as we can to meet the requirements around this. But to adjust for that, assuming that, July 1st, there's people who would qualify for an exception and need it, we are making sure that no hours are reduced while the exception is being approved. So if an exception is submitted, the current hour allocation will remain in place until the department has completed their review. So that is how we are mitigating for risk starting July 1st and making sure that we're not missing anybody who would qualify. We also really heard, because as I talked about at the beginning of this presentation, this regulation applies to both agency-based care and self-directed care, where in the role of consumer-directed attendant support services, or CDAS, they are the employer. So we made those changes to make it really clear. Where we had provider agency, we added the term CDAS employer, or FMS contractor, which is fiscal management services agency, to make it really clear how these regulations apply across all service delivery options. If we can go to the next slide, please. So I just want to land with the key takeaways here for this rule. I certainly wanted to make sure that I created plenty of time for questions and feedback and for us to hear testimony. The 56-hour cap moves away from a system of having a single caregiver dependence towards a more sustainable model of care. And this is really grounded in member safety and long-term sustainability for these services. This policy will not reduce the members' authorized services. Authorizations are based off need, and they will remain unchanged. This rule implements an exceptions process for those members who truly require one caregiver or due to workforce shortages and/or medical fragility. So we have worked really hard to figure out what is the right safety net around this policy. And back to my opening comments, I hope that people can see how their feedback and their insight has really shaped that work for me and my team. And instead of this immediate implementation, we are looking at phasing this out over a whole year to give people time to mitigate any impact that might have for their individual circumstance. With that, I am happy to take any questions that the board has.
Thank you, Bonnie. I appreciate you like always. Board, I would like to give everyone a quick reminder. I saw some very, frankly, impactful and interesting questions and comments in the comment chat. Please keep in mind that we are an open air board, so any questions, comments, statements, any of that stuff need to be done on public record and spoken whenever possible. So the first person that I saw who had comments in the comment field was Mr. McLaughlin, and then second was Dr. Martin. So I'm going to hit Tiny first, and then we'll come back to Barry. Let's go.
Madam President, this is James McLaughlin. Let me start by saying I'm sorry. I was a little bit impassioned during Bonnie's talk and did not realize that the comments weren't available to the public. So I'll share those now. So Bonnie, I just wanted to say thank you for taking the time to acknowledge the impact that these changes will have on the folks that that have historically taken care of their loved ones every day. This is going to be hard for them, and I appreciate you taking the time to acknowledge that and for helping us understand how we got here. Also, I want to thank you for taking the time to talk about protection for providers. These family members take on a huge responsibility when they care for their loved ones. And so often, without fully making sure that they're taking time to take care of themselves. And I have seen in my profession time and time again where family care providers have died, frankly, from not taking care of themselves and putting all their energy into taking care of their loved one. And that doesn't help anybody. And so I do appreciate hearing that, that there is some consideration for that, because I think that's important as well. I think what we're seeing here is we're in a really unfortunate position, and I see these folks that are losing some of these services as victims of a larger problem in the healthcare system, and that is just the incredible growth of fraud, waste, and abuse in the healthcare system. We've seen it in the ambulance service where shady ambulance companies park outside of dialysis clinics trying to talk people into catching an ambulance ride home from the dialysis clinic. We've seen it in NEMT over the last several years. And we've seen it in the durable medical equipment environment. And every single time a shady organization goes out and leverages a service like this service in a way that negatively impacts those who most depend on these services, this is the impact. It's less availability of service for everyone else. And I am so sorry that we got here. And my goal from here on is to protect this benefit and all the other benefits for Medicaid members to the best of my ability. So thank you for taking the time to explain this and help us understand this. And this is a very, very hard thing. I've spent a lot of time over the last several months thinking about this. So that's it. Just thank you.
Thank you, Mr. McLaughlin. Ms. Bonnie, did you want to say anything or do you want to keep rolling?
I deeply appreciate Mr. McLaughlin's comments, and I think that we should keep going. Thank you.
Thank you, Bonnie. Dr. Martin, you have the floor.
Hi, I put a question in the comment section, which I can identify just so everyone knows what it was, but it's really the least of my questions. I'd asked about provider agents, what provider agency means, because they would have a role in determining whether an exception was needed, and that I was like, who exactly is this? It didn't seem to be the case management agency. So I think Chris was nice enough to answer for me who that was, the service agency. So I think I got the answer to that one. So my two bigger questions is the first is basically what happens if we don't approve this? It seems like it's a accomplished fact. The legislature mandated it, and like James mentioned, and like you mentioned, Bonnie, I've been agonizing over this, but then it seems like the decision has already been made, and is really, if we don't approve it, I'm assuming it goes into enforce anyway, since it's state law. So that's my first question: is what happens if we don't approve this?
Madam Chair, would you like me to respond?
Sure, I was waiting to see if he was going to stack you with questions. Go right ahead, hit that one first.
Thank you. Thank you, Madam Chair. Thank you, Dr. Martin. I do want to clarify the provider agencies, our service agencies. My gosh, we have so many different ways of framing them. But more importantly for the board, I want to articulate that who we mean by provider agency is defined in regulation. So there will be no confusion around who this applies to. So we have HCBS provider agencies. We also have home health agencies that would be impacted by this rule, and of course our self-directed options. But your bigger question of what happens if we don't approve this, that is a challenge, and part of the challenge is typically my office would do stakeholder engagement, and then we would come to Medical Services Board for approval. The series of regulations that I have had before you, or my team has had before you, related to sustainability, have all worked their way through the state legislature as part of the governor's budget and what they use to balance our state budget. And in this case, because a lot of the testimony was really impactful, we actually worked directly with the legislature to outline things like the year-long implementation and the requirement for an exceptions process, not all of the details, but there's a little bit more meat on that bone than typically we would have through the budget process. And so it is state law, right? So I have the legislative branch directing me via state law to implement this. And now I need to seek authority from this independent rulemaking body to say, this is the how I am going to implement that state law. And here's how I'm responding to those requirements. And so the Medical Services Board role here is really focused on the how I am implementing this law. And is there any feedback for me from your perspective based off testimony? But I am on the hook for implementing it, the state law and the associated savings with it in either case. So I'm hopeful that going forward, we can kind of get out of the federal law, state law, MSB law, but I think those intersections sometimes are just unavoidable.
So I'm still not quite sure what happens if we don't approve it, but I guess I don't know. I can go on to one of my other questions, and that is, this is a solution to solve some problem or problems, and it's not completely clear to me what problems we're trying to solve with it. It seems to me that when I first heard about this, it was because of, the Medicaid sustainability, money needed to be saved, there's huge cuts that are due to the Medicaid department. And so this was emergently necessary to try to stem the budget crisis, but then it actually wasn't projected to really save all that much money. I think $2 to $3 million out of a multi-billion-dollar budget. And so then it's, well, we're trying to solve the problem of caregiver burden, not making it people work 112 hours a week, 3 times as much as a normal job would be. But it's, that it doesn't sound to me like that's a problem that the caregivers feel like needs to be solved. And it doesn't really sound like it's going to affect the fiscal issues very much. So my question is exactly what is this meant to solve?
Go ahead, Bonnie. Thank you, Madam Chair. Thank you, Dr. Martin. In the presentation, I tried to give a nod to this. The goal of this regulation is it's actually attempting to solve multiple problems. And I will say I have perhaps not been very articulate and really framing that in a way that lands for people, as evidenced by your confusion. So it really is aimed at three things. There is the fiscal sustainability of this policy. Can the state afford to pay 112 hours a week for family caregivers? And part of what I didn't get into a ton of depth here is that, on our long-term home health side of the shop, this policy was more longstanding. As we moved into implementation of Community First Choice, that policy then expanded to even more people. And what we are seeing is that there's a rapid number of people again, being authorized to provide that 112 hours of services at a rate that I think we have to say as a state, is this the right policy for us from a fiscal standpoint? Is this something that we can afford in the long term? And that is where we looked at, like, nationally, what are other states doing about this? And how do we make sure that we're in alignment? So there is a fiscal component in terms of, like, how much money are we really saving, and is the juice worth the squeeze, which is what I think you're asking, is that, we were really intentional with putting dampeners on the savings to make sure that we weren't backed into a corner as a state for achieving savings that would be a challenge for us in terms of what we want is a diversified workforce. What we want is to have a policy. So the second thing that we're trying to achieve is to make sure that we have a policy that really requires more than one person providing the care on a regular basis, that requires more diversification as a safety net for that person who is receiving the care. And I think that's the third component of, for the member, how do we have programs and policies that better support them receiving care from people who are rested and well equipped to meet their needs as they need them to. And this is certainly not me saying family caregivers aren't doing a good job and they're not, extraordinary in all the ways that they're showing up. It is me saying that as a state agency looking at what is the policy that we want to put in place, it is not one where somebody is regularly working 112 hours a week for people who have really complex care needs. And we need to have some better safety parameters around that to have assurances around the quality of care and for the member. And also, if something happens to that caregiver, how do we mitigate sort of the impending crisis that might happen? Does that answer your question, Dr. Martin?
It does. And if you'll allow me to ask one more, I think I'll be done.
Hit it, Dr. Martin.
Thank you. My third question is, it was very compelling to me when I read through a lot of the written testimony. Several people pointed out that, especially for people with autism or who have behavioral challenges, having a stranger come in to provide some of their care, one would be, an indignity if it's someone they don't know well providing personal hygiene, for example, and others that, for some people with autism, I've got one patient I can think of myself who, if anyone comes into their house, even a homemaker or anything, the person gets very, very upset. So for a lot of people, with the individuals who will be affected by this, having someone else other than their family member come in and provide care could be really destabilizing and distressing for them. So that is also a concern of mine.
Madam Chair, thank you, Madam Chair. Thank you, Dr. Martin. That I agree. That is a compelling component of the testimony. One, I want to highlight that there's a reason why we worked to clearly define what the exception process includes, but we're also really clear that it is individualized based off of the often unique and complex needs of the population that we're serving. And so, how a person's disability manifests in relation to new caregivers will be a component of what will be reviewed. I would also say that perhaps especially for people who really struggle with new people coming in, there has to be some plan in place, especially for the long term, that says maybe when your mom and dad are not able to provide that care, because that point often comes, how do we start slowly, intentionally bringing in new and different people in a way that is not completely destabilizing, but ensures that we have an actual safety net in place? And so we're going to be looking to achieve both of those outcomes.
Thanks. That's all my questions for now.
Thank you, Dr. Martin. Dr. Kennard, you're next in line on my screen.
Thank you, Madam Chair. Mostly a comment with maybe a little question. The comment is I also reviewed all the written input line by line 2 or 3 times, highlighting points and taking notes. I think I want to assure the attendees that I'm sure all my colleagues did the same. And what I came away from that review was a couple of things. One is there clearly was a lack of trust that the exceptions process was going to work. And I think you did your level best at addressing that in the presentation. And I found it reassuring, and also the slowing down of the pace was encouraging as well. But I think, again, the test will be what happens in the wake of passing this, if it is passed. So I think I just wanted to applaud, because it really is about the exceptions, because there clearly are people that will need them. And then secondly, and sort of in response to Dr. Martin as well, is I kind of realize I'm the old guy in this room, and so it's sort of my job to be the Medicaid historian. And Medicaid has a now 60-year history of well-intended attempts to solve problems, and it's been very effective in many ways, and it's also had lots of unintended consequences. And one of the consequences is we created these incredibly heroic parents here in Colorado by paying for them. And so the stories of the moms who are the only people who can recognize an impending seizure, and I mean, all these just heart-wrenching stories, I get it. And I also realize that to some extent, these policies that have been in place have created that person, have enabled that person to become that sole point of failure. And that's our fault in the medical establishment. And that just can't go on. And I would say it's interesting to me in terms of problems is that in other meetings we've heard about, the state pays for 30 hours a week of outside of the home care for kids with autism. 30 hours a week. That's trying to solve the problem, part of it, that Bonnie's talking about, of the fact that a person can only be around one other person is a problem. And because that person is not always going to be there. And so using that as a reason, I think is sort of self-defeating, and also further burdens that single person. So I thought that's why we're investing all this in care of kids on the autism spectrum. So I think our history is one of good intentions that have created another set of problems. I think this is although I agree with Dr. Martin, I don't see how it's going to save a whole lot of money. I think it probably will save some. And I'm convinced that you are sincerely and gently addressing a real problem. So,
Bonnie, did you want to respond?
Thank you, Madam President. Thank you, Dr. Kennard. I just want to speak to the lack of trust, and I certainly have heard that, felt that, read that, and so before you, I have an emergency rule. We'll, if it passes, be looking to implement, monitor. We'll continue to take feedback and be back before you in 120 days. But then our work doesn't stop there. Our commitment is to continue to listen, evaluate. Where did we get it right? Where do we need to adjust? And how do we move this forward in a way that people can move from, I think, the fear that they have now about what will happen to an understanding of, okay, here are the new parameters, and I can trust that they will be implemented as designed. And that is our goal and our commitment to the community and certainly to this board. And I appreciate your comments on the heroic efforts of family members just giving everything they have to their loved ones, and they cannot be the only one. And so I appreciate you recognizing that we are trying to honor both of those.
Thank you, Bonnie. Did that take care of you, Dr. Kennard?
yeah, absolutely. Thank you.
Wonderful. Thank you, sir. All right, Bonnie, here's your next one. Hello, Dr. Littler.
Hello, Cassie Littler. I have a couple of questions. My first one actually kind of goes back to what Dr. Martin was talking about provider agencies. I actually think this is a really important point. Many times, caregivers have more than one provider agency that they're working with, like a home health. They are a CNA through a home health provider, but then they also work with a case management agency for other services, is my understanding. Is that correct?
Yes, Dr. Littler.
Okay. And so I think one point I wanted to know is, how would a caregiver or a provider agency know that a caregiver is at a cap of the 56 hours once it gets to that point, or that they're at the, at those going down from the 112? If, for instance, they were at the 112 and they were coming down, how would one provider agency know what the other provider agency is at in terms of providing that number of hours? Because it's all encompassing, right? Like if they're a CNA for a home health company, but then they're also doing work through the other service agency for their family member, how does that work?
Madam Chair, am I good to respond?
Please feel free, Bonnie. I would love this to create a dialogue environment, because that's kind of where we are.
Thank you for that permission. I appreciate it. Thank you, Dr. Littler. That's a great question. And that's actually something that between the emergency passing of the rule and the final passing of the rule that you'll see some updates. But the plan is that the provider agency, the department will create a document that to be shared with their caregivers around, attesting to that, look, you are capped to provide 56 hours of care per member. Here's the responsibilities around that. I want to make sure you understand that. And when they're submitting the request to the department, there'll be a box that they check that, yes, they shared that information with their caregivers. They attested that they understand it. And we understand that, like, they won't actually know what the caregiver does across maybe multiple agencies. But when we're looking at how we implement this regulation, I believe strongly the simplest path forward is the best path forward, and that, making sure the regulatory and legal requirements are shared with the caregiver, they have some obligation. And then the provider agency certainly will attest to that. If they find out that they're working across multiple agencies at more than 56 hours, they have a responsibility to then act and address it. And, when we monitor the implementation of this rule on the back end, we will be simply looking that they have shared that information, they have attested to that information in its implementation.
I have a follow-up question. This is Cassie Littler. Do the family caregivers get direct communication about this or about their hours and what's approved, or does that go just to the case management or the provider agency to share with the family caregiver?
Thank you, Dr. Littler. So caregivers would get that information from their provider agency. The provider agency in this circumstance is going to be the one communicating directly with the department. And we are the agencies, we will be communicating back to the provider agency, and then they will be sharing the outcome with families.
Okay, this is Cassie Littler. So for a caregiver who's working with multiple agencies, they should, in fact, hope to receive information back about, for instance, an exception process or something, if they're doing that across multiple provider agencies.
Yes, Dr. Littler, that is accurate. They will be required to disclose. So part of the information that their employer, in this case, the provider agency, will be sharing is like, hey, you have a responsibility to disclose if you're working with multiple agencies, and you have a responsibility to let us know, or to stay within that 56 hours. If the provider agency says, look, we believe that, the exceptions criteria is met here, we're going to submit that. Their employer will be submitting that to the department and then sharing it.
Okay. And if I may have just another question, sorry if that's okay with everyone, before you go, Amanda. This is Cassie Littler again. Is there an appeals process for an exception denial?
Thank you, Dr. Littler. That is a great question, and one I intended to address in my presentation. Because we are not reducing services to the member, this is not a deniable action. It's not an adverse action to the member. So if they're authorized for, let's say, 80 hours of care, and the provider agency submits an exception for that caregiver to continue to be the person providing that 80 hours of care, and the department determines that they don't meet the criteria for exceptions, the 80 hours on their service plan is not reduced. The expectation then is that there's reason to think that they would have other care providers come in and fill in the hours above the 56 that the one caregiver is giving.
Thank you. This is Cassie Littler again. So in that time, say that the exception is denied, would the family caregiver continue to receive, payment for those services until an outside caregiver is found, or do they just not get paid for that time, even if it takes, many weeks or months to find an outside caregiver?
Thank you, Dr. Littler, for that question. So while the exceptions process is pending or being reviewed, the hours that the caregiver has in place will remain. After the department has issued our decision, the provider agency has 7 days to comply with that decision.
And if they cannot comply with that decision, what happens? This is Cassie Littler. I'm just thinking about a family who's in a area, I don't know. I'm just assuming that might happen.
It certainly might happen. We certainly would be working with that agency to understand where the difficulties were or are and how we can best support them in that.
That was Bonnie Silva speaking.
Oh, thank you. Thank you, Madam Chair. I appreciate it.
I'll stop asking questions. This is Cassie Littler, so other people can chime in. Thank you for your time, Bonnie.
All righty, Dr. Jaslinski, you're up. And let's continue if we can just acknowledge who we are, but keep it conversational so that you guys can get to the bottom of what you need to.
Sounds good. This is Dr. Amanda Jaslinski. So Bonnie, I just wanted to bring up a couple points that were raised in some of the written testimony that we received. One point was some folks just wanted to clarify that there are states that have higher caps on caregiver hours, which I'm assuming, is because they also have different budgets and maybe taxpayer dollars in other opportunities to provide more, but I didn't know if the department or anyone had a response to that because it was cited, brought up a few times, states like California and Washington and things like that. So that's my first question. In I guess, and to make it a proper question, like how did Colorado determine its current cap compared to the ones like states that have a higher one?
Thank you, Dr. Jaslinski. Your name is very difficult for me. I apologize. This is Bonnie Silva. I really appreciate that question, and I also read that in the written testimony. And can I just say, like, researching this information online actually isn't as straightforward as you might think. And so part of what we did is we did end up reaching out to sort of our colleagues around the nation to better understand. But some of the states that were referenced in the written testimony, like California, for example, they can get 66 hours a week. That is when they are providing care to more than one member. So their one member cap is at 40. And so 66 is for two members. And so there's just some nuances in there. And I'm not saying that we get our research right all the time. Again, that is not straightforward and it is ever evolving. But there are some nuances there that should be considered.
This is Amanda Jaslinski. Thank you for your response, Bonnie. I think my second thing is more just a comment, but just acknowledging the fact that a parent will always know their child the best. I don't think there's any way. I love outside caregiver. I think outside caregivers can be amazing people who provide great support to families. But I will say that, like, as a mom, I just think that a parent will always understand and know their child the best. I mean, from a basic standpoint, I have a 3-year-old. I understand 99% of what she says verbally. Another person is not going to understand her words that well. And we know this about children and their development, and that their parents understand their verbal communication better than strangers, or not even strangers, just like better than teachers and other folks. And that's just part of being a parent. And so I wanted to acknowledge the fact that there were very many parents who wrote in saying there's just no one who can replace my depth of knowledge in caring for my child. And I think that that's true. I don't think that there's an outside caregiver that will ever be able to do all of that. At the same time, I think two things can be true. And while that parent is the one who has the most knowledge, without additional support from outside caregiving, it does put both the child potentially at risk if something were to happen to that caregiver, and the caregiver at risk for the mental and physical toll it takes on them. So I think we do need to come up with a system that provides them with more support. I think it's also really important to acknowledge, and this is where I would like so much follow-up after this, if this takes place. Workforce shortages are really very, very real, and we hear about them throughout a lot of aspects of Medicaid services in Colorado. I also feel that, as people said, the paying for caregivers was potentially, I'm not a historian of Colorado Medicaid like Dr. Kennard and some of my colleagues, but potentially a workaround given those workforce shortages in the past. And so I think it's really important that we really closely monitor, to Dr. Littler's point, how many times there might be an exception where the agency cannot fill that need. How often is it happening that, a family cannot find an adequate caregiver? Because I know the department has done work to try to improve wages for caregivers and things like that to try to improve the workforce situation. But it's probably my number one concern with all of this is that there might be limitations for individual caregivers, and there will not be the workforce there to supplement the gap.
Thank you, Dr. Jaslinski, for those comments. If I may just quickly say, I agree. I think the close monitoring of the data and implementation will be essential to understand where we may need to make adjustments. And I will also say that, this policy will actually help provider agencies, or perhaps force provider agencies, to move away from a disproportionate reliance on family caregiving and be more active in their recruitment of non-family caregiving options for people so that they have the appropriate backup care in place. And I would say across the whole system, right, when we're looking at 55,000+ people in the community, there's pockets where we do really, really well. And so leveraging some of those strategies and making sure that we're deploying them holistically will be, I think, essential in making sure that the significant investments that we've made in workforce, to the tune of over $600 million, are realized here in Colorado in meaningful ways. So thank you. And please know that we will also be monitoring very closely to understand.
That was Bonnie Silva. Did you guys want to keep going, Amanda?
No,
Thank
you. This is Amanda. I'm all set. Thank you.
Wonderful. Dr. Martin, I see your hand again, sir.
Yes, thanks for indulging me. Maybe I'm the second oldest person on the board behind Dr. Kennard. I've been around the block a little bit. And in my, experience, I would say that when we didn't rely on and didn't support family caregivers, what happens were the regional centers in Colorado. I'm the medical director of the regional centers, and there's lots of people who have spent their entire lives there. They're elderly now. They were dropped off as babies and have been there their entire lives, and that's because families didn't get the support they needed. And so I think, yes, we have families who are super involved in taking care of their very complex, or their children with very complex healthcare needs. But I think that's what we wanted. It's not a bad side effect in my view. And the other thing, to me, in saying that we need to provide support for caregivers, I've got, to use another example from my practice, a mom who's taking care of her son who has, very significant needs, and she's with him all day and then up half the night with him. And she's had trouble getting support at night from someone who could do things like do the deep suctioning that he needs at night. So I think when caregivers ask for support and they need support so they can get sleep at night or go to the grocery store or that kind of thing, I think that makes sense, but not a hard cap that just says, after 56 hours, you have to stop. I know all the work that's gone into this rule, trying to make this work, at the JBC on down to us, but so far, I just don't see a compelling need for this. It's not clear to me what it is we're trying to solve. It won't save much money. It's not what caregivers want. In many cases, it won't be to the benefit of the individuals being served. So that's my thoughts so far.
This is Bonnie Silva. Thank you, Dr. Martin, for those comments. We have an obligation to always keep at the forefront the lessons that we have learned historically. I think I have 28 years in this field, and I know I have much to learn from you and others that have been here even longer. I think that your point around, having a hard cap isn't going to work, which is why it's now has an exceptions process. When understanding that we serve people with really complex needs where emergencies are going to inevitably pop up, which is why we evaluated how our emergency process would work to wrap around this. And so we have really worked very hard to be responsive to the needs of this community while also putting forth what is a necessary policy to ensure I think long-term better outcomes for the people that we're responsible for, the Medicaid members, the caregivers that support them, and the sustainability of our system overall. And so this is incredibly difficult and impactful. And I'm hopeful with the additional structures that we've put in place, including documented workforce issues. I hear that be a concern of many board members and the community as a reason for an exceptions process to help us move in this imperative direction.
Thanks.
Hey, Bonnie, this is Laura Carroll, president of the board. I was wondering if you could take a moment and outline what that exception process is going to look like for the people who need them so that they can feel confident that when they need an exception, that it's going to be a plausibility.
Thank you, Madam President. So the exceptions process will be managed through their provider organization. So their provider organization will look at these rules and say, absolutely, you meet the criteria. Let's go about submitting it. That provider organization will be responsible for working with that caregiver and that family to gather the necessary information to document that the exceptions criteria is met. They will be responsible for coordinating with the case management agency if that person also receives case management services to ensure that we have good communication and review of what we're asking for. And so the case manager will ask to do a review of that exception since they're responsible for authorizing a good component of those services. But the provider agency will submit that exception to the department for review, and then we'll communicate directly with the department. During that time period, caregiver hours will not be reduced. They will remain in place while we are conducting our review. If we're doing the review and let's say we have additional questions, it is intended to be a back and forth, not a one and done and try again. And if we need additional information, we will ask for it. To get the best outcome possible, the most accurate outcome possible. And then once that decision is issued, again, there's 7 days for compliance if it's denied. And otherwise, it will go into effect for up to a year. And again, these are very individualized reviews. So we are hoping that this process is transparent, that people can understand what we're trying to achieve, that we've heard the feedback and we've made those changes. I also want people to hear that as we implement, we're inevitably maybe not going to get it right. And you have our commitment to evaluate it and make sure that if there's areas that require refinement, that we will do the good work to make sure that that happens.
Thanks, Bonnie. It's Laura again. What kind of time frame are we committing to these parents who are going to need these exceptions? And of course, we don't ask for an exception until we need it now, right? So what sort of time frame are we looking at for these parents who realize that they need an adjustment to CAP? Often they're going to realize it once it's probably pretty late along in the process, right? So what kind of commitment are we making to our communities when we get those exceptions, how quickly we're going to be able to put through good answers?
Thank you, Madam President. This is Bonnie Silva. I appreciate that question. The goal here is for us to get the review right, which is why we are allowing the hours to stay in place during that review period. We also understand that it is June 12th, and we are looking to implement this on July 1st. So I imagine that, this first go around, the Department and Regulations has 30 days to review that exceptions. And so that goes past the July 1st date, and that's okay. If the exceptions are submitted, we have 30 days to conduct our review. And again, during that time period, those hours would stay in place. So that first phase is between July 1 and 31st. And then hopefully as we move forward, right, there's broader awareness, we've implemented, there's more time. And then of course, an emergency exception, to your point, Madam President, can be submitted at any time. And well, the emergency doesn't require review. That can be up to 7 days. So the agency has the ability to implement immediately if an emergency exception is required. And then if another review is required by the department, we would then have the 30 days. I would say that so between July, everyone's going to submit exceptions that are over that 84 hours. All the reviews from the department will happen in August. So if they submitted a exception in July, those hours would stay in place. Department will complete our review in August. For the phase 2, agencies will submit exceptions between November 1st and November 30th. The department's review will happen in December. And then in phase 3, exceptions will be submitted in May. The department's review is in June for implementation. So we really worked hard to allow some space and time for thoughtful review to happen.
Sorry about that. Thank you, Bonnie. I appreciate it. As reading and listening at the same time, I'm just not that deep. Okay, so I just want to make sure I understand. So family A has been in that 80, it's going to be in that new 80-hour cap. And then they find out that they need more than that. I'm talking like today they need 80 and something has changed that now bumps that to 90. Let's say, let's just use nice clean numbers, right? So are you telling me that their organization is going to be able to upfront say, yes, do those 10 hours, do what you need to do. We see you, and then they're going to fight with you on the backside for that? Or is this going to be something where when people realize that they have an increased need that comes in that sort of fashion, where they're going to have to wait until they have approval to make that change? Did that question make sense?
I think so, Madam President. This is Bonnie Silva. We go back to the criteria that, what meets criteria for emergency, where the provider agency has the authority to say this meets criteria for emergency, go ahead and implement it. And then once it's submitted to the department, those hours can stay in place until we have conducted our review. So we're not asking for hours to be reduced proactively. We are asking hours to be reduced after we have conducted our review, if that's appropriate.
This is Laura Carroll. Thank you, Bonnie. That was the kind of information I was looking for. I wanted to make sure I understood. Thank you so, so much. I yield over to Dr. Jastrzynski, please.
Thank you, Madam President. This is Dr. Amanda Jastrzynski. I just wanted to bring up Dr. Martin's point of whether or not this will yield significant savings, given all the concern. And I think this is, Bonnie, I would like your input on this as well. My understanding with several of the issues that we've faced over the past couple months is we need basically more regulation in Medicaid spending to ensure that the dollars that are being spent are doing so appropriately. And that's not to say that any of the families that wrote in are not appropriate recipients of those dollars. They absolutely are. But we also, as a board, faced several other emergency rules that were put in place due to concern that there were situations where dollars had been spent potentially inappropriately or had led to, for lack of a better word, fraud. And that is something that also came up in some written testimony that was submitted. So I guess my question to you, and to Dr. Martin, is whether placing caps that can be exceeded with the process that you outlined, Ms. Silva, allows the agency to better regulate and have oversight on how dollars are being spent. Because ultimately, I would be in favor of supporting families well. And I would also hope that if we can have better regulation, we would be able to find more dollars to support the families that need it.
This is Bonnie Silva. Thank you, Dr. Jastrzynski, for that, I think, question of me. There is so much happening in the Medicaid space right now. So much happening, so much national dialogue, so much state dialogue, especially around fraud, waste, and abuse. And I want to say that that work is essential. It's something that Colorado, along with many of our colleagues around the nation, are taking seriously and looking at, our efforts to identify proactively or address fraud, waste, and abuse in our Medicaid program. But I also want to be really clear, like this policy proposal is separate and apart from that. Like if we just look at it standalone and take all the noise around, potential audit findings or fraud, waste, or providers that are not good actors doing not good actor things, impacting how dollars are spent. This policy, again, is aimed at achieving really several outcomes at once. One, is it reasonable for a single caregiver to be providing 80, 90, 100 plus hours of care per week? And is that the best outcome for the people that receive services? And how do we make sure that there's a growing need for long-term care, that we have a sustainable system for many, many years to come? And part of that, an essential component of that, is building a diverse workforce. And right now, 112 hours per caregiver, what we are seeing is an over-reliance on family caregivers. We are seeing an over-reliance on one caregiver at the expense of sort of the broader workforce, at the expense potentially of that member. So I want to be clear. I am not saying families are doing anything wrong. And if anything, I deeply appreciate their passion, their care, and dedication to their loved one. So there's no fraud that we are sort of asserting here. We do think that right, wrong, or indifferent, like your policies incentivize certain behaviors. And this policy has incentivized an over-reliance on family caregivers in a way that we are not sure is fiscally sustainable. That is a component of what we're trying to solve. That is not the totality of what we're trying to solve. And so we are looking at this from a fiscal standpoint, but we're also looking at this from a care standpoint. So standalone from sort of all the noise around fraud, waste, and abuse, we're really looking at this policy and how it impacts people with disabilities and their caregivers, and what is the right approach for Colorado for many years to come. And in working with our broader community, we believe that the policy put before the board is a appropriate and necessary action to achieve those three outcomes.
Thank you, Ms. Silva. This is Amanda. I have no other questions.
Thank you, Dr. Jaslinski. Dr. Martin.
Welcome back.
Back again, Barry Martin. So I originally raised my hand when the concern of fraud came up, and my comment was going to be that if we're trying to solve the problem of fraud, there are other ways to solve that other than a strict cap on family member hours. So that doesn't seem like fraud is something we should always be on the lookout for, but this is not, to me, the best solution for that. The question, is it reasonable for people to provide 100 hours or 112 hours a week of care? I think if we give them the help that they want and not just deny their own care, it seems to me like that would be the solution to relieving their burden, is to help them, to take some of the burden off their shoulders, not to tell them you'll only get paid for this amount of care that you're providing every week. So, yes, I still don't get that.
This is Bonnie Silva. Thank you, Dr. Martin. I deeply respect and appreciate your perspective. Unfortunately, having a 112-hour-a-week cap hasn't resulted in necessarily people getting the support they need, or to have a diversification of the workforce, or bringing in alternative caregivers. And so as a state, we are looking at not just the caregiver's perspective, but the member's perspective and sort of the impact of our policies on them. And how do we better make sure that our policies drive the right outcomes? And so I think that if the 112 was used as the, exception and not the norm, and we had other caregivers coming in regularly, that would be more workable. Unfortunately, I think we're not heading in that direction. And so want to make sure our policies are driving the right outcomes. And that would be having a more sustainable workforce and one that is rested and well capable of caring for the complex needs of the person before them.
Thanks, I appreciate that. And I think you were going to hear from lots of outside community testimony here coming up. And I think we're going to hear that, well, maybe they don't like working 112 hours. They're not supportive of this solution to it. So we're saying we're doing it for the caregiver's benefit, but maybe we're not hearing from the caregivers who think they will benefit from this. But I think we're going to hear from several who say this, it's not, they don't think they'll benefit. They don't think this is a good solution. It's not going to meet their needs. So thanks for your comments.
All righty, Dr. Littler.
Hi, Cassie Littler. I wondered if the department has an estimate on how many family caregivers will be immediately impacted by this change from 112 per caregiver to 80. Like, I'm assuming there's sort of like a subset of caregivers that we know are at 112 and will be going down, and kind of looking at that group and just thinking about as transparently that kind of discussion that I think Dr. Jaslinski brought up, like having some eyes on how many are approved and how many are denied. So just wondering if you have any estimates or thoughts about that.
This is Bonnie Silva. Thank you, Dr. Littler. I'm trying to look through my notes to get my data numbers top of mind here. So what our data shows is we have 1,467 people that are currently over 80 hours. So, and up to the 112, and that is across all of our home and community-based CFC services and long-term home health. I want to just clarify that what we don't have line of sight on is, again, this is a caregiver cap, not a family caregiver cap. So while I think that we have almost exclusively heard from family caregivers in relation to this change and their concerns with it, I can't tell you how many of those are family caregivers versus not. Our data doesn't separate out things that way. And I can't tell you how many of those are the only caregiver in the picture for the person.
Thanks for that. So this is Cassie Littler. So there may be many of these, 1,400, over 1,400 people who, so these are the patient themselves that have over 80 hours or people over 80 hours, but we don't know if that person has 40 hours with one caregiver and 40 hours with another caregiver. So, so they may not need an exception to be reviewed if that's something that they wanted to do. Is that correct?
This is Bonnie Silva. Thank you, Dr. Littler. That is correct.
Okay. This is Cassie Littler. I was just trying to figure out, like, if you have 30 days at the department to review 1,467, because I'm assuming people would want to put in an exception, that just seems overwhelming. So just trying to think about how this is going to look in real life. So I appreciate your numbers and your data.
Are you all set, Dr. Littler?
Yes.
Wonderful. James McLaughlin, the floor is yours.
Thank you, Madam President. Bonnie, and forgive me for my poor memory. What was when you originally presented some of the changes that were coming, you talked about growth. I can't remember if it was in this rule specifically or in another one. You had talked about a percentage and increase that was a pretty astronomical number. Do you remember what that number was, what the percentage and increase you've seen in the utilization of this program and the cost of this program?
This is Bonnie Silva. Thank you, Mr. McLaughlin, for your question. one of the reason why long-term care is so front and center in many of these conversations is, we have this significant structural budget deficit that we're trying to solve as a state. Medicaid is such a huge component of our state budget. And, the services in my office are 45% of the Medicaid budget. And so prior to the public health emergency, the COVID-19 public health emergency, the year-over-year annual rate for growth in my office was around 5%. And that was from like fiscal year 16 to fiscal year 20. From fiscal year 20 through 24, that has jumped to 19%. And so this reduction that is before the board is one of many that we're looking at. How do we make sure that we have better predictability in the year-over-year growth of long-term care in totality? And so this is one piece of a much bigger puzzle to make sure that collectively we have confidence. Yes, we have high quality care for people who need long-term care in Colorado. We can catch it. We can make sure that you have services. So this is a component of that, because when we look at the impact of HR1 on our state, when we look at the requirement to have a balanced budget under Tabor, long-term care can't continue to grow at a year-over-year rate of 19% and or higher, and not have some pretty impactful outcomes for either other Medicaid providers or other state agencies. So we are trying to make really strategic and intentional changes that keep intact the broader sort of program and access and quality in ways that we can see where the growth is targeted, or we can see where our policies are out of alignment, and being thoughtful about how we can sort of pull those back in ways that have a meaningful impact.
Thank you, Bonnie. The follow-up question: if we as a group fail to take action, if we as a group don't find ways to control these costs, is it safe to say that there will be even more profound impact on members going forward?
This is Bonnie Silva. Thank you, Mr. McLaughlin, for your question. Yes, it is safe to say that. And I think that is very difficult for people to hear, especially when faced with such an impactful change for them personally. One of the pieces of feedback that I've heard, especially pretty early on, was you should be advocating for across the board cuts, and that everyone's taking a cut, and instead of these strategic, more intentional, targeted policy actions. And the issue is that the margins are already so small for many Medicaid providers, but especially long-term care Medicaid providers. And the more across the board cuts that we're taking, the less likely we are to have a provider pool at all to render these care. So we want to just really be thoughtful about how can we maintain our reimbursement structure so we can maintain access to, they can continue to recruit people to provide the care, family caregivers, non-family caregivers. We need to be able to pay for these services. And even if they did these deep across the board cuts, if we don't take action where our policies are out of alignment, or maybe not where we're supposed to be, or where the trajectory of our spending is unpredictable, then we'll continue to have expenditures that we're like, oh, we can't get our head around this. Now we need to take more action and take more action. And so trying to put some better proactive guardrails in place around how and when these services are authorized and accessed gives us better assurances along the road around avoiding those deeper, more impactful cuts.
Thank you for that.
Are you all set, Mr. McLaughlin?
I am. Thank you, Madam President.
Oh, Dr. Martin.
And Bonnie, I think you said, the projected savings of this is 2.7 million. Maybe I think that's one number I've heard. And you said maybe that's, kind of a underestimation of what it could be. What do you think best case scenario would be if best is saving money? What's the most amount of money you could project this change making?
This is Bonnie Silva. Thank you, Dr. Martin. You know, I intentionally asked for a conservative estimate for cost savings associated with this change because the best case scenario for all of us is that we are building up that diversified workforce, and that is sort of the primary intention around this policy. I think that the savings was around I can't remember off the top of my head. Y'all will have to forgive me. It's between 2.7 and 2.8 million once fully actualized. And I think that is easily achievable as a floor. And I don't want to guess at what it could be. What I want to do is focus on how do we implement this thoughtfully, intentionally, monitor, look at our expenditures, look at our exceptions process, what have we learned, and then revisit it from a cost saving standpoint to understand what is actually saved for the state from a fiscal sustainability standpoint. So I would be remiss, mostly because I don't work in the finance office, with saying, well, if we included these other assumptions, here's potentially what we could save. I will say that, given the rapid uptick in utilization of this core set of services, I would imagine that if we were to rerun those assumptions today, even, that it would be a little bit higher. But again, saving money is essential, but it's not primary in this policy proposal.
Great, thanks.
Mr. McLaughlin.
Thank you, Madam President. And just to follow up on Dr. Martin's last question, is it so? And if you don't know the answer, that's okay. But what I heard was those cost projections were on current, or those cost projected savings are on current costs and don't actually account for cost savings going forward. Like you were talking about, this program continues to grow, and bringing that growth into control would render additional cost savings into the future. Is that correct?
This is Bonnie Silva. Thank you, Mr. McLaughlin. That is correct.
All righty, James, have we got you there?
Yes, Madam President. Thank you for the time.
That is what we're here to do, my friend. Do we have any other questions from the board? All righty, hearing none, we will commence public testimony in 5 minutes. This Miss President needs a bio break. Thank you, team. Hello, everybody. Welcome back. We are getting situated over here, so I'm just going to hang out for a quick second while my partner in crime, Mr. Sykes, gets himself where he needs to be so that we can start with public testimony. Let's get people talking.
Okay.
Chris is heading over to his desk to let us know who is first for public testimony today, team. Oh, yeah, you know what? It's time to probably make a quick little announcement too. Thank you for the reminder, Mr. Sykes. I appreciate you. On the website and both at the top of the meeting, we did mention that we were closing invitations to public testimony at the head of the meeting today, which we did. We have had some people try to sign up since the commencement of the meeting. And because we have so many, this is such a long meeting and so many hot topics and so many things to get to, I'm making the managerial decision that we are going to stick to that. So if you did sign up once the meeting started this morning, we are not going to be able to hear you today. But this thing's going to be back to us again from the best that I can calculate 2, if not 3 more times. So those folks who signed up, who missed that deadline, you will have tremendous and ample opportunity to share your feelings. I would also encourage you to please send them to us in writing. We're always happy to see them. But because those are the rules we made, those are the rules that we're going to follow. So with that, I'm going to ask Mr. Sykes, who do we have up first for public testimony today?
This is Chris Sykes. We have Casey Barrett.
Good morning, Casey. I see you.
Yeah, can you hear me?
I do. Good morning, Casey. You have the floor for 2 minutes.
Good morning. My name's Casey, obviously. I'm a single father and primary caregiver to my almost 15-year-old daughter, Olivia. I was at the April meeting. I don't know if you guys remember me or not, but Olivia is nonverbal and medically complex. She has a rare neurological disorder, intraceable epilepsy, chronic respiratory failure, restrictive lung disease, CP, profound hearing loss, cortical visual impairment, dependent on G-tube, BiPAP, and supplemental oxygen. Because Olivia cannot reliably communicate when something is wrong, continuity of care is not a preference for our family. It is part of her medical care. Before I became Olivia's primary caregiver, she was hospitalized 6 times between the years of 2018 and 2022. I became her primary caregiver later in 2022, and since that time, she's been hospitalized once. That dramatic reduction in hospitalizations does not happen by accident. It happened because consistent caregiving allows problems to be recognized and addressed before they become medical crises. My concern is that this exception process appears to assume a workforce that it does not exist. One of my daughter's fellow students, her family's been on the Medicaid waiver for 2 years and has been looking for an overnight caregiver for 2 years and has never filled that position. Families cannot hire caregivers who simply just do not exist. One thing that's also to point out is this supposed to be a participant program, so a member gets to choose if they want a different caregiver or not. This exception process requires families to document recruitment failures, but many of us have already been documenting those failures for years. If the workforce shortage is already known, why must families reportedly prove it before they can maintain care that is already working? And finally, I continue to struggle with one question. If a caregiver can safely provide 56 hours of care to one Medicaid provider and 56 hours to another, why is the same caregiver prohibited from providing those same 112 hours to a single medically complex child or adult whose assessed needs require them? I respectfully ask that the board consider continuity of care, documented health outcomes, and the realities of
All righty,
Colorado
that's time, Casey. We appreciate you so much. Thank you so very much for your testimony today. Do I have let's see, do I have any questions from the board? Hearing none, what we're going to go ahead and do today, team, is we're going to get some testimonies in, and then we're going to allow Bonnie to give a response to several of them at a time. This is in the interest of time and continuity. So if there's no questions from the board, let's go on to the next person with public testimony. Who would that be today, Mr. Sykes?
This is Chris Sykes. We have Bryce Rafferty.
Good morning, Mr. Rafferty, or is it afternoon already? It's afternoon. Hi, Bryce.
Hello, can you hear me?
I can hear you, sir. 2 minutes for you.
Good afternoon, Madam Chair, members of the board. My name is Bryce Rafferty, and I'm speaking on behalf of the Colorado Cross Disability Coalition. The CCDC supports the intent of this emergency rule with the understanding that HCPF will continue working with us and with other stakeholders to revise and improve the rule before final adoption. This rule sits in a difficult but necessary context. Colorado must pursue long-term care sustainability and respond to increasing federal program integrity scrutiny. For example, recent CMS actions in other states like California and Maine imposed payment deferrals to the tune of billions of dollars based on home health and provider oversight suspicions and concerns. These alarming tactics show why states need clear, defensible policies for Medicaid home and community-based services. At the same time, sustainability cannot come at the expense of the people that these programs exist to support. A caregiver payment limit can become a practical service reduction if members cannot find a replacement caregiver or navigate the exception process. We understand why the department is moving towards limits that reduce over-reliance on a single paid caregiver. Colorado has lost parts of its traditional direct care workforce, and rebuilding that workforce is essential, but caps alone will not solve the problem. The state must also take affirmative steps to address workforce shortages, expand the pool of available direct care workers, and improve the resources that connect caregivers with members. That includes strengthening caregiver recruitment tools, improving the Direct Care Careers website, or comparable platforms by operationalizing data to monitor the workforce in real time and making those resources usable for members and authorized reps. Also helping members to identify workers with the right skills, training, availability, and geographic context. For that reason, CCDC support depends on HCPUF's continued stakeholder collaboration to address outstanding issues, including that people receiving fewer than 56 hours of direct care per week are not required to complete unnecessary attestations to reduce paperwork, separating service delivery models clearly in rule and guidance because they all operate differently, creating reasonable and realistic exceptions process and longer emergency exceptions compliance periods, and publishing plain language tools.
Bryce, I'm
so
sorry,
families
we've hit
face
time,
their
my friend.
advocates.
Thank you so much for
Just
your
finished.
time this morning, sir. Thank you.
Thank you.
I see your hand, Mr. McLaughlin.
Yeah, thank you, Madam President. James McLaughlin. Bryce, thanks as always for being here. Quick question. You hinted at it already, but how would you define or how would you describe the stakeholder engagement around this rule up to this point? And what do you anticipate it will be like going forward?
Thank you for the question, Mr. McLaughlin. This is Bryce Rafferty with CCDC. As an emergency rule, up to this point, the stakeholder engagement has taken the form of surveys and I believe 2 or 3 iterations of the rule. In other words, you have to have filled out a form, received an email and filled out a form, and also been available to either take part in a stakeholder engagement webinar or watch that in the aftermath on YouTube. I have seen tremendous amendments and revisions to the rules relative to the first draft. But I think the only way that this rule is going to work in practice is if we have a continued collaborative effort, not just with advocacy organizations like CCDC, CCLP, Family Voices, etc., but also a very intentional, direct, accessible manner for members and parents and stakeholders to identify and readily point out how to make this program work operationally, achieve its goals, achieve administrative efficiency, and actually save money while building the direct care workforce. I think the Rural Sustainability Initiative program is a very good example of a tool that might alleviate some pressures here. It's not the one listed on the actual rule itself, but I'm sure the department knows what I'm talking about. It's a heat map that identifies by county proportions of caregivers per member, and with the information being collected by provider agencies, skill sets, experience, availability in terms of how far someone's willing to drive, hours worked, those things can be put in there too. And so we can have a very dynamic tool that would be realistic and easily accessible for members. I mean, things like that and iterative improvements to the language as well will help us stay compliant out of the Fed's target and really helping members mitigate this as best they can, understanding that this is not an ideal situation for anyone.
Is that good for you, James?
It is. Thank you, Madam President.
You betcha. Dr. Martin, I see your hand.
Thanks. In my ongoing quest to understand a problem that this solution will solve, one of them is building a healthcare workforce. By creating demand for healthcare workers, we'll help to build a workforce. Is there, Mr. Rafferty, would you say there's a current demand for healthcare workers, the kind of caregivers that would fill these roles? is there currently a demand that is, or is it saturated and more demand is needed to bring more people into the jobs?
Thank you for the question, Dr. Martin. This is Bryce Rafferty with CCDC. I would say right now demand outpaces supply, and there's also issues with within the actual direct care workforce specific to the type of service rendered. In other words, institutional settings often, if not always, seem to provide higher wages, better benefits, and are more attractive than home health and LTSS options are right now. The Bureau of Labor Statistics has shown that, and in the past 6 to 8 years, only 5% of the direct care workforce has been in home health, while well over half is in facility-based care or institutional settings. During that time, the actual percentage has remained the same over the past 8 years, but the gap in wages has grown such that it favors institutional or facility settings even more. So I think two things. We need to make that demand, we need to make the direct care workforce actually understand what jobs are available in the long-term services and supports and home and community-based services areas that we're discussing here. We also need to take intentional measures to make those openings more appealable and competitive, so that the direct care workforce is not being drawn more towards the institutional side of things that actually cost more money and is obviously less preferable for members, and I think the state at large is trying to save money here.
Madam Chair, if I could follow up.
Let's continue on in the good effort of conversation whilst identifying ourselves. Carry on.
It's Barry Martin. So it sounds like, Mr. Rafferty, you're saying that the problem is not paying caregivers enough. And I assume you think that this proposal that we're talking about would increase the pay for caregivers and so make more caregivers willing to work in the community setting rather than institutional setting?
Thank you again for the question, Dr. Markin. This is Bryce Rafferty again with CCDC. I think the direct care workforce and the payments being offered, that is a separate issue that I think needs to be tackled in tandem, in parallel with this initiative. It's not outlined in rule what the actual pay rates are, and there's a lot that needs to go into that. I think there needs to be interagency collaborations here. I think there needs to be work between, say, the nursing board and the Department of Healthcare Policy and Financing. And we need to look at how we can actually improve the direct care workforce, sustain it, and make these community-based jobs more attractive, while also ensuring that people have the skills to fit that. And so it's one, making sure the workforce is available, and two, making sure that we can connect caregivers with the people that need the specific care in community settings. And three, we need to make it more competitive and make it easier to actually monitor the success of whether or not what we're putting on paper is actually playing out in practice.
This is Barry Martin. Thanks for that clarification, and thanks for all the work you do on behalf of this community.
Yes, sir.
I would like to second that. And also, does anyone else have any questions for Mr. Rafferty today? Hearing none. Bryce, I always appreciate seeing your name, if not face, in our meetings. You help a lot of this feel like easy language for all of us. Thank you so much for everything you do in the name of our communities. Mr. Sykes, oh, you bet. Who else do we have today, Mr. Sykes?
Sykes, we have Chloe Weber.
Good morning, Chloe. You have 2 minutes to tell us what we need to know.
Good morning. I will try and be pretty quick because my kid is ready to go party with me. So first, I'm just really confused and sort of insulted to hear you guys talk about, or some of you talk about how this is to protect caregivers. This bill only saves money if we are unable to find caregivers for our children. So that is baked into the bill. And if you're estimating $2.7 million, that's an estimation of approximately $90,000 of unpaid medically necessary care to the most vulnerable Coloradans that we have. So to me, as a mom, as a doctor of Chinese medicine, as a solo caregiver to my child with STX-BP1, I find that honestly quite insulting and pretty heartbreaking. So let's just be honest about what we're talking about here. This also only accounts for 0.18% of the budget deficit for Medicaid for Colorado. So really, we're not saving any money here. Sorry, I'm a little flustered. Medical service boards, I've been on too many meetings with you guys than I can count this year, and I found you all to be very reasonable. I am asking you to please just make sure that the exemptions are very clear. Consider single parents in this situation, as well as rural communities, complex care, nonverbal children. Please, please help us make sure that we have a clear, hi Remy, clear path towards getting a sustainable exemption without burning ourselves out and losing our minds. This is life altering for our families, and I really appreciate your help in everything that you're doing. I really appreciate the questions a lot of you have brought here. Thank you.
Thank you, Chloe. Anybody from the board wish to ask any questions or speak with Chloe? Hearing none, do not take that any particular way, Chloe. We are grateful that we got to hear from you, and thank you for being so concise and putting us exactly where we need to be.
Thank you.
And who do we have next, Miss? We had no questions from the board, so who do we have up next for testimony, Mr. Sykes?
This is Chris Sykes. We have Neil Shermer. If I said that wrong.
Neil, we hope we got your name right.
Yeah, you nailed it. Can you hear me?
We can hear you, sir. You've got
Great,
2 minutes on the
thanks.
clock, and you just made Mr. Sykes's day because he got your name right. Off you go.
Nailed it. Yeah, thanks. Sorry, I'm public speaking is a weak spot for me, so I apologize for my fumbling here. So yeah, I'm part of the torrents of criticism of this rule, and I'm honestly kind of shocked. It feels like this whole process is a bit broken. If we are moving forward with this with some amount of some sense of inevitability, in the face of that of so much concern being expressed from the public and stakeholders and families, and again, I've observed the MSB. I really appreciate the work you do. I understand it's thankless, and that's I'm just like, this whole issue seems to come down to, it seems like it hinges on the assumption that there are going to be other caregivers there. And Dr. Martin and others, really appreciate a lot of your questions. A lot of you clearly get it. And that seems to be what to me is missing here, that like, how would this rule come about if people in positions to shape and create this policy truly got it? Because to us, the family caregivers, the other people, the other caregivers giving care to this extremely vulnerable population, we know that pay just isn't there for caregivers. There just aren't enough other people to help us. So basically, I'm just asking you to reconsider this, and I'll just leave it at that.
Thank you, Neil. We appreciate you. Do we have any questions from the board? Hearing none. Thank you very much, Neil. Who is up next, Mr. Sykes?
This is Chris Sykes. We have Victoria Moole. Said that correct.
Once again, I'm getting a gosh, I hope I said that right, Victoria.
Sorry.
Well, it's Mel, but not one single person ever gets it right, so don't feel bad.
We appreciate your flexibility with us. Chris is flogging himself appropriately. You have 2 minutes.
My name is Victoria Mel. I have a bachelor's degree in family studies with emphasis in adolescent psychology. I have 15 years as a social worker in the adolescent realm. I have 9 years as a CNA in good standing for 3 teenagers. I have 7 years as a nonprofit director. I have 4 years as a volunteer advocate. I've got 5 years on 3 different county boards and almost 2 years on a state board. That is exactly my resume, my work resume that's on Indeed and LinkedIn. That is a cumulative time of very hard work, career climbing, exhaustion, education, and lots of student loans. In the workforce, I am deemed as a very highly sought after worker. The reason why is because of my resume, because of my accolades, because of the work that I do, not only in my private life, but out in the real world. And I just want to say very, very firmly, I have been given multiple job offers for over $120,000 a year because of my education and my experience. The only reason that anybody would suggest that I lose pay or hours is because you guys know that the 3 people that I provide services for are related to me and live in my home. If I were out in the real world, in the workforce, in the diversity you're talking about, nobody would think twice about the hours that I work or all of the dedication or longevity that I have towards my career. Instead, the state has decided, because I happen to be a live-in caregiver, that you take all that experience, education, and my dedication, shove that over into the living caregiver bucket, and then take that bucket and shove it into another bucket called prejudice. And I would like to say very plainly, I need 3 CNAs, 1 to provide care for each one of the children, an RN to come in to provide other skills the CNA can't.
Victoria, I'm going to stall you and I'm going to stop the clock a second because you were cutting in and out. We're going to give you a couple extra seconds. We lost you a few seconds ago. So we're going to stop the clock. I'm going to let you get back in there and tell me what we missed.
3 CNAs.
I got 3 CNAs and then I lost you.
Okay, can you hear me?
I can hear you now. You were definitely fading in and out, but the last thing I heard you say was 3 CNAs.
Yeah, so I need 3 CNAs, 1 RN, and then teachers because I also homeschool. Once I have those in place to provide care for my children in my home, I am more than happy to go out into the workforce and go get one of those state jobs that you guys have and be very happy with my $120,000 plus a year. That's all I have to say. Thank you.
Thank you, Victoria. Do I have any questions from the board? Hearing none. Thank you, Victoria. We do appreciate you. Who do we have signed up next for public testimony, Mr. Sykes?
This is Chris Sykes. We have Cassie Smith.
Good morning, Cassie.
Hello.
2 minutes on the clock for you. Go on ahead.
I'm just going to read what I have written. So here we go. Good morning, and thank you for allowing me to speak. My husband, Brandon, is a medically complex individual with quadriplegia who depends on extensive daily care to remain safely at home. He requires assistance with transfers, bowel and bladder care, wound care, medication administration, feeding tube care, tracheostomy care, including suctioning 24/7, catheter care, mobility, and nearly every activity of daily living. Additionally, Brandon has significant communication limitations related to his condition, I'm emotional, and is often unable to speak clearly enough to be understood by unfamiliar individuals. As his primary caregiver, I am frequently serving as an interpreter for a communication and support person, helping medical providers, caregivers, and others understand his needs, symptoms, concerns, and requests. In the last 5 months alone, Brandon has been hospitalized twice, inpatient, and has 2 additional emergency room visits due to his complications. He has severe wounds requiring ongoing care, a history of serious infections, including VRSA, not MRSA, VRSA, a very rare infection, and continues to face significant barriers accessing specialty medical care. We are still waiting for appointments with wound care, infectious disease, pulmonology, neurology, orthopedics, and other specialty cares despite multiple referrals. The reality is that Brandon's care does not stop after 56 hours. They exist 24 hours a day, 7 days a week. As his primary caregiver, I provide consistent care giving that keeps him out of the hospital and prevents the institutionalized placement. I do not have help overnights, and I'm unpaid for that already. I am already paid very little for the amount of care I provide. If my hours are reduced, I will likely have no choice to return to outside employment to support my family. At this point, we will be forced to depend on finding caregivers who are available, qualified, and willing to care for Brandon's complex care. Unfortunately, we have already struggled to find reliable caregivers despite extensive efforts at an RN level. If that care cannot be found, Brandon is at serious risk of losing support that keeps him safely at home instead of remaining with his family.
Cass, I'm so sorry. Your time is up.
Well,
Thank you
he'll end up inpatient.
I'm
if no
sorry.
one
Thank
cares
you for
about
your
him.
time today, Cass. I really do appreciate it.
I'm sure you
Do we have
do.
any questions from the board? Hearing none. Cass, we appreciate you. Do not think your voice is unheard. It is heard loud and clear, I promise. Who do we have set up next for public testimony, Mr. Sykes?
This is Chris Sykes. Sorry, just looking over the list. I believe, and Kelly, jump in if I am missing something, but I believe that is everybody that we have signed up for document B. Unfortunately, we did lose some individuals, I'm guessing by the length of the meeting, but we have at least, I think, 4 individuals that were not online. And Kelly and I have been looking.
All right, I do see a message from Kelly that is where we are. Okie dokie. So, Bonnie.
Thank you, Madam Chair. I just want to acknowledge the passion and the fear and frankly, the exhaustion that I'm hearing in many of the testimony from the community. Please know that we hold that very, very, very tightly, and we consider it as we're crafting policies and helping us determine how we move forward. I do think that, I certainly hear from some members, like, please just don't do this at all. Like, if we think this is the wrong policy. And I deeply appreciate that perspective, and also think that if we continue not to take action, then the challenges that we have with the 112-hour cap will continue. The risks that we have with the 112-hour cap will continue. Looking at quality of care, I think, is essential. I certainly heard just frustration of we wouldn't necessarily choose to do this if there was a more diverse workforce out there. And, I mentioned during my presentation that we've invested $600 million into wages. And, we actually require providers to attest that they're paying people with those increases at a higher rate. And we don't differentiate between paid family caregivers or regular caregivers. And have made substantial progress in that, and have seen the ability to recruit, attract, and retain workers to this field as an outcome of that investment that Colorado has made. We are seeing that, when we started this work, people were making just over $12 an hour, and now we're at, on average, again, over $21 an hour for this essential work. And so we are making progress. We're also seeing that as provider agencies are perhaps overly relying or recruiting family caregivers and not looking to a broader workforce, we're we need to rebalance that and make sure that we have both so that it's truly a choice to be that primary caregiver, and it's truly a choice in terms of how that care is set up. And so having a diverse long-term care ecosystem really is essential, and this regulation is an important step in that reduction. I also want to say it is the provider's responsibility to be recruiting, seeking, attracting, retaining a workforce. They have a responsibility when they raise their hand and say, yes, I can serve this person, to cultivate the workforce to do that and to do that well. And so, we are looking to them to do that. I also just want to reiterate our commitment ongoing to stakeholdering and the stakeholder process. It doesn't stop today with the emergency presentation. We know we have more work to do. One of the things I think that Mr. Rafferty mentioned in particular was, caregiver attestation. I think initially we were like, how do we manage caregivers working across multiple agencies? And really, based off feedback from stakeholders, we're like, we're going to remove that component and just figure out how we can simplify this process. I also hope families hear that the workforce challenge, the continuity of care, member choice, hospitalization risks are all components of what we must consider when looking at that exceptions process. And we worked to implement that clearly in our regulation and our process for how we're considering this impactful regulation as it's moving forward. So I thank people for elevating their voice, for offering their criticisms, for giving us their feedback, and know that I am listening, my team is listening, and will continue to listen as we move forward here in Colorado.
Thank you, Bonnie. Mr. McLaughlin, I see you as hand number 1.
Thank you, Madam President. Bonnie, I want to thank and recognize Casey, Bryce, Chloe, Neil, Victoria, and Cass. I want you guys to know your voice was heard. We really appreciate you taking the time to talk with us today. I want to go back to what you were talking about, Bonnie. I think you picked up on it really well. It sounds like workforce is a real challenge. And I know we have talked about the extensive effort that your group has put into working with and developing workforce. And this question may be for you or it may be for somebody else within HIGPUF. But my question is there an opportunity for organizations and grassroots groups to leverage some of this rural health transformational program funding to help shore up the workforce and develop a stronger workforce in this arena?
This is Bonnie Silva. Thank you, Mr. McLaughlin, for that question. I am not leading the department's rural transformation work, so I don't want to speak too far outside my swim lane, except to say that people with disabilities, how to support them, are certainly a core component of how we're guiding that work. And so exactly how that is panning out, I don't have top of mind, but I know up front, those were the values and sort of parameters that we put in place to guide the work. So I can't imagine a world in which it isn't impacting the long-term care community. Also just want to say for the rural areas in particular, we have, and workforce, like we have been leading long-standing cross-state agency, cross-community efforts to say what are the right strategies to really build up and recruit this workforce. And I am not going to stand before you all and the members of the community and say, Colorado has it all figured out. There's no problem with workforce, but I am going to say that we have made substantial progress. We have an infrastructure in place. I think you heard our direct care workforce. We have an online platform to directly connect people seeking care, people who want to be caregivers. And, we have better line of sight than we've had historically around sort of what is the need for workers versus the actual workers available and how do we close that gap. And so, again, those are things that we are committed to dive deep on ongoing to make sure that our strategies are effective and to work with our broader community on.
Did that take care of you?
It did. Thank you, Madam President.
Wonderful. I have a order issue to bring up. Okay, good. So Dr. Littler, Dr. Martin, you are my next two questions, but we have located one of the people who was supposed to give public testimony. So we would like to give them their 2 minutes to say what they'd like to say. And then we will come back to the board questions, and Dr. Littler, you'll be first, and Dr. Martin, you'll be second. So who do we have for the public testimony, Mr. Sykes?
This is Chris Sykes. We have Deanna Cairo. And Deanna, I apologize for missing you on this spreadsheet.
I will flog him, Deanna, I promise.
No, that's okay. I actually also signed up to testify for document 5, and I wasn't called on for that either, and I couldn't like raise my hand or anything. So I would appreciate it if we would reconfigure how we're handling these meetings in the future, because there's no way for the public to really engage if there's a problem. And so I'd also appreciate it if you'd reset my timer for my testimony. Thank you.
I will take care of both of those things for you. Thank you very much for bringing us awareness. I don't see all of that information. I am getting and giving looks to my admin across the way so that things like this do not happen in the future. Deanna, you have got 2 minutes when you are ready to start talking.
Thank you. And it's Dina. I am
Dina, sorry.
That's okay. I'm the president of COAID. I did submit written testimony on the 56-hour caregiver cap that I'm going to be referring to you. But I want to talk today in my testimony about my concerns with this as a medical provider. I'm an APP working in neurology, and I care for patients with brain injury in my outpatient clinic. I have multiple patients on the BI waiver that will be adversely affected by this measure. None of them have any family caregivers. For example, I have a young woman who sustained a severe TBI a year ago. She has a feeding tube, moderate cognitive impairment, severe spastic quadriplegia. And after her rehab stay, her parents moved her back home, and she currently qualifies for 126 hours a week of care. Presently, she has a single outside caregiver that provides 86 hours a week and another outside caregiver that provides 40. And so she is going to be reduced by 14 hours under the proposed rule whenever it goes into effect. The 40-hour caregiver does not want to do any overtime, and her agency has not been able to find another caregiver. The agency wants her RN mother to pick up the 14 hours while they continue to look, and her mother does not want to do this. She's employed outside the home, and she receives a far higher rate of pay for her job as an RN in a hospital than she would receive for providing CNA level care for her daughter in the home. The patient's also being cared for at Children's for primary care. She's quite young, and her primary care provider has told the family that they were instructed by Children's Administration not to provide any special letters or exemptions, as everything that is needed is contained in her medical record. So there goes any exception request. And so, Dr. Martin, I also happen to be an attorney, and I wanted to take a crack at answering your question with my viewpoint. It's just my view. But if the MSB fails to implement a proposed rule here, there will be no way to administratively enforce this rule at the OAC. This will simply be a policy that HCPF will try to enforce. And a recent case in in Pennsylvania called Dunkelberger had a very similar situation. There, in that case, the Pennsylvania court struck down a situation where the Department of Human Services had entered a rule capping care at 40 hours a week for family caregivers. A mom provided more than that.
Ma'am, I'm sorry, that's time. We are so grateful for actually all of that, including your professional information on that. It's extremely helpful. Dr. Martin, since she mentioned you specifically, did you want to ask any questions?
Not necessarily about that, although it's still not really clear to me what will happen if we don't pass this, but I did have a comment unrelated to her testimony.
Well, if you don't mind, Dr. Martin, since Dina did get passed over, I want to make sure that if any of our board members have any questions for her directly, that we hit those first, so that we at least try to regain some fairness in that part of the process. Is there anyone on the board who has specific questions? Hearing none, thank you, Dina. I am so sorry that happened. I will be meeting with the team this week and we will try to make sure things like that don't happen again. Thank you so much for bringing it to our attention and for your testimony today.
Thank you.
Appreciate it. All righty, so we're back to our questions to Bonnie, and I had Cassie first. So Dr. Littler, you first, then Dr. Barrett, then Dr. Martin.
Thank you. This is Cassie Littler. I think there's a lot of discussion about the direct care workforce shortages, and I just wondered how in the future we're going to be monitoring those. I think Mr. Rafferty had talked a little bit about the kind of heat mapping with other provider types and wondered if that's something that the department is looking at. Because it seems to me that we can't really currently tell who the provider agencies are paying for family caregiving versus community-based caregiving by these direct providers. So just wondering about the strategy and monitoring going forward of the workforce shortages.
This is Bonnie Silver. Thank you, Dr. Littler. We have a whole variety of metrics related to the direct care workforce. We are the ones that developed the heat map for rural communities to better understand where we may have care deserts. We work with both national experts to understand demographic shifts and sort of how many workers are we going to need now into the future, and how do we develop strategies to close that gap. And so again, we have a lot of data and efforts around direct care workforce in general. I think we are looking at what is the line of sight that we need to have on direct care workers versus family caregivers. That's sort of a question mark for us. Certainly, as we are implementing this change, one of the exceptions reasons is a documented sort of workforce challenge that can't be overcome. We'll be gathering that data as part of our overarching workforce strategy to give us better line of sight on where our strategies might have holes in them or where we might need to bolster it a little bit.
Thank you.
Oh, Dr. Martin.
Thanks, Barry Martin. One of the first presenters this afternoon said something that raised an issue that I hadn't thought of before, and that was that in a person-centered system, the person receiving services should be able to determine who their providers are going to be. And I wonder if that seems like a legitimate right of a person to choose their providers. How do we square that with limiting who their providers can be or how much time their providers can devote to them?
This is Bonnie Silva. Thank you, Dr. Martin. Choice is an essential component of the long-term care system. Members do get to choose which provider agencies they work with to a lesser extent, but certainly more important, they get to choose who comes in and provides the care in their home. And all of those choices and protections remain in place. This policy is not limiting who they choose. It is placing a cap on the number of hours that an individual caregiver can render to a member, which is less about their choice and more about the state having a policy aimed at ensuring that caregiving that's provided is done in a reasonable way that assures the caregiver can thoughtfully, restfully provide said care and get quality outcomes to the member. Of course, there will be those circumstances where exceptions are important, and that's why we have that process in place.
Did that do you, Dr. Martin? Wonderful. Any other questions from the board? Hearing none. Okie dokie, team. I will accept a motion on document B.
This is James. I can make that motion.
I appreciate you, sir.
Absolutely. Give me just a second to find it. All right. I move, and this is document A, correct?
We are on document B, my
B,
friend.
sorry. Yeah, B. All right. I move the emergency adoption of document B, MSB 26-05-05-B, revision to the Medical Assistance Act rule concerning caregiver limits, section 8.520 and 8.7400 and 8.7500, incorporating the statement and basis and purposes and the specific statutory authority contained in the records.
Thank you, Mr. McLaughlin. May I get a second, please?
This is Dr. Kennard. I'll second that.
Thank you, Dr. Kennard. All in favor, please say aye.
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 All opposed.
Opposed.
I hear one opposition. Any abstentions? I hear none. Mr. Sykes, please check me on my math, but I believe that document B has passed. Is that correct?
This is Chris Sykes. Yes, you are correct. The vote was 8-1. We had Morgan Honey leave at noon.
Okay. All right, ladies and gentlemen, document B has passed emergency adoption. And we are now on to document C. Miss Bonnie, do you need a break? Or are you ready to rock and roll?
I am ready to rock and roll if the board is ready to rock and roll.
Coochie coo, mama, go.
All right, if we can move to the next slide. The second rule that I am here to present, sorry, for the record, this is Bonnie Silva, and I serve as the Director of the Office of Community Living. The last time I was before the board, we were presenting final adoption on a regulation that would have capped legally responsible care of homemaker services at 10 hours or 5 hours with a cap of up to 2 legally responsible people. The board was, after hearing testimony, concerned about the impact that that regulation, if implemented in that way, would have on single parent households. I'll be honest, in that moment, I was like, I don't know, I don't have budget authority to increase my budget, but let me take your feedback. And I went and worked with the Attorney General's office to understand what it was that I needed to do to meet the requirements of the General Assembly while also being responsive to the board and that feedback. So what the feedback there was because this really is about achieving the savings associated with this change. The policy wasn't prescribed by the General Assembly, but I had some nimbleness in how I achieved those savings, which is good news. So I could be responsive to the board. But I'm on the hook for achieving the savings. And so we then did the work to say, okay, how do we achieve those savings and also be responsive at the same time? So we worked to change the policy to allow up to 7 hours per week of legally responsible homemaker. And just for reference, legally responsible homemaker, legally responsible person is a parent of a child, a guardian of a child, or a spouse, to 7 hours per week. And it doesn't matter how many legally responsible people are providing it. It's 7 hours per member. It's capped. So for the households that maybe had 2 legally responsible people, up to 10 hours per week previously with the regulation, they now would be receiving a little bit less at 7. And for the households that only had 1 legally responsible person rendering the care, they're now receiving a little bit more at 7 hours. We have pushed these regulations out to the community for feedback. We've received a lot of support and believe that with the board's adoption of this rule will be good to fully implement. With that, I will take any questions.
Thank you, Miss Bonnie. Do we have any questions from the board? Barry Martin.
Thanks, Barry Martin. I think I probably missed this because I missed the previous meeting when this was discussed, but what are the duties of a legally responsible person? I tried Googling it just now, but I couldn't Google it fast enough.
Thank you. This is Bonnie Silva. Thank you for that question, Dr. Martin. I think it depends on who we are talking about. A parent obviously has different legally responsible obligations to their child, or a guardian of a child, than a spouse may have to their partner. It also depends upon to some extent, the age of the child. And so it's a more nuanced response than what I would like to be prepared to give to you. But I'll use an example. A legally responsible person for a 3-year-old child, all 3-year-olds require line of sight when they're in the bathtub, right? They can't be left alone. They require hand over hand assistance in making sure that they bathe appropriately. Like, I haven't yet to met a 3-year-old that can do that solely independently. And so there is some expectation from our federal government around when we're crafting these policies, they consider the things that legally responsible people would be required to do no matter what. And that we, Medicaid, aren't paying for things that legally responsible people should be required to do. The inverse of the example that I just gave is, let's say a 14-year-old needs line of sight supervision and hand over hand assistance with bathing. That is not typical responsibility. And so that is something that Medicaid could pay for. So it is a little bit more nuanced, but there is some expectation that outside of just general family caregiving, right? So if I, as a daughter to my mother, decide to be a paid family caregiver, I'm not legally required. I don't have any legal obligation to her. And so that is my choice there. Or even if I'm a parent choosing to provide care to, say, my 25-year-old child or adult child, there's no legal obligation for me to do that. So when looking at those smaller subset, there's some expectation that our policies reflect that they have obligation to provide care, and that Medicaid isn't supplanting that obligation.
This is Barry Martin. Thanks so much.
Do I have any other questions from the board for Ms. Bonnie? Hearing none. Mr. Sykes, do we have anyone signed up for public testimony?
This is Chris Sykes. We did have individuals signed up to provide testimony. Kelly and I have looked through the online meeting. We cannot locate, let's see, individuals Cindy Colwell or Victoria Wilcox. Those are the individuals that have signed up for testimony, but they are not in the webinar.
Either one of you ladies, if we are missing you, would you throw up a hand, an emoji, send a smoke signal, something?
That is
counting down.
Madam
Yes.
Chair, this is Cassie Littler. Sorry,
Hello,
just feedback.
Cassie Littler.
I think I just wanted to mention from one of our previous testimony people that I know on the last meeting when I was in the webinar, not as a panelist, you cannot raise your hand or chat. So I just want to point that out again.
Splendid. I appreciate you setting me straight. I have not sat in that space.
If I may, Madam President, this
Please,
is Chris
Mr. Sykes.
So what Kelly and I do in the attendees portion of the webinar, we can actually search for names. So as you have signed up on the testimony sign-up sheet, Kelly and I will go and we'll search for the individual, and both Kelly and I have not been able to locate either Victoria Wilcox or Cindy Colwell.
And on that note, also, Kelly put in a message while Chris was explaining that to you and clarified that, yes, standardly it is correct. But if I ask him to, he can make it so that people can react, raise their hands, do all of that thing. And that we did not receive any positive input from either one of those people. So it sounds to me like we do not have any more public testimony lined up for today. Is that correct, Mr. Sykes?
This is Chris Sykes. That is correct.
All righty. Then I would accept a motion on document C.
This is Chris.
Oh, go ahead.
Who was that, James? Okay, it's Christina. I've got it.
Thank you, ma'am.
I move the emergency adoption of document C, MSB 26-05-05-A, revision to the Medical Assistance Act concerning legally responsible persons homemaker hours, section 8.7500, incorporating the statement of basis and purpose and specific statutory authority contained in the records.
Thank you. May I have a second?
Barry
This is
Martin, I'll
Amanda.
second.
I heard Barry first. I'm going Barry. All in favor, please say aye.
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 All opposed? Abstentions? All righty, document C passes emergency adoption. Look at this, kids. I'm going to read a closing motion. Are you ready? Move that all rules adopted at this meeting of the Medical Services Board of the Colorado Department of Healthcare Policy and Financing meet the criteria of the State Administrative Procedures Act, which are incorporated by reference. All righty, team. Can I get a second on that?
This is Amanda, I second.
Thank you, Dr. Jaslinski. With that, team, we are in adjournment. Oh, what did I miss?
Consent.
Oh, thank you. I'm so glad Chris is here. Let's talk consent agenda real quick, team. I kind of felt like everything that went through initial today did pretty well and would be reasonable on the consent agenda. Do I have anybody who disagrees with me?
This is David. I completely agree with you, and I also think we should put minutes on consent.
Oh, I was hoping someone would bring that up. You're the best, Mr. Pump. Thank you. Does anybody have any objections to moving minutes to consent agenda? Hearing none. Mr. Sykes, starting next month, would you please include approval of minutes in our consent agenda? Thank you.
This is Chris Sykes. Yes.
Thank you kindly. And with that, team, we adjourn. Have a great month. Thank you. I know this was hard, and I'm really looking forward to seeing everybody in person really soon. I'm getting waved at. What did I miss, Chris?
Oh, no, this is Chris Sykes. I'm sorry, I was down at the I was down at the closing, but we got the consent discussion done.
Excellent.
Right? Yeah.
I did it. We did it. Good job, team. All righty, everybody. I will see you all next month, hopefully in person, you guys.
Yeah.
Thanks. Be well, everybody.